sessions. Today, we'll be covering aortic root, thoracoabdominal aortic aneurysm, TAVI, MICS Bental, and perfusion management. So let us begin our academic feast with aortic valve and root management. So the chairperson for this session are Dr. Anshuman Mandal, Dr. Binay Krishna Sarkar, Dr. Manoranjan Mishra sir, Dr. Sanjay Sen sir. Kindly chair the session, please. I request Dr. Vikas Kesari sir to chair the session, sir. I now request Dr. Prasanna Sema sir, Professor and Head of the Department CTUS, Shri Jayadeva Institute of Cardiovascular Sciences, Bangalore, to share his experience on Ozaki procedure.
This is forward. Yeah. This is pointer. This is pointer.
Yeah. Good morning, everyone, and I thank the organizers and Dr. Bose for this invitation. I'll be sharing with us our currently 9-year data about the Ozaki procedure. Yeah. Okay. We started many years back with doing the Ozaki. When I initially started it, when we saw the report by Ozaki, we made the initial sizers with the edge of the cardioplegia box. It was curved, so we made these sizers like that based on the measurements which he did. And we started doing the Ozaki procedure based upon those sizers. And we did the initial ones and we compared it with mechanical valve replacement, and we found excellent results. We published it in our journal after some time, and we found excellent LV mass regression, good valve area, so we continued to do that. And later on, we started 3D printing, and we made, see, these are not the original Ozaki sizes, but they were made. So we made these sort of sizers and continued to do it rather. I know people have, some of them have eyeball taking measurements, so we wanted to have a standardized way of doing it, and so we 3D printed these things and made our own sizers. And we have been regularly a part of the Boston Children's Hospital registry, and we've been following up. And this is around 278 patients which we have been doing, and as you can see, a large volume of the young patients have been done. Contrary to what Ozaki has done, Ozaki is more of elderly people, but we have got a wide distribution, but we enthusiastically tried to do it, especially because rheumatic patients, not easy to repair, repairs don't stay well, and we've got issues about anticoagulation, especially in poor economically, and we need to give them, and if a child gets a mechanical valve, he won't go to see adulthood. So we thought that we could do these sort of cases, and that's why we have larger, but please remember that most of these are non-repairable valves. We would prefer to repair them as far as possible. And as you can see, we've extended, initially we were doing it as an isolated procedure, but you can see now more than 50% of them are with a concomitant procedure, because a large volume of double valve patients come with for a mitral valve repair with the Ozaki. And we have extended it to, so you can see there's a wide varying amount of this thing depending upon the type of case that we do, but we have become better and better, and even my colleagues are doing it. And you can see a wide variety, the youngest being 4 now up to 75, and cross clamp times have gone up and down depending on the complexity of the cases. And we can see that we have had excellent LV mass regression over the cohorts. And we've had good preservation of ventricular function. There is some amount of values where regression has not occurred because we've taken patients, some of them with very poor ejection fractions, and the main thing that has happened is we've been able to allow them to get better medical therapy, but their EF may not have improved. But then you can see that we've had significant reduction in volumes over time and LV mass. But the most beautiful thing about this operation is because it's essentially a stentless operation, and we've got good valve areas, and consistently we get a valve area too. I'll be highlighting on this because this is a problem in children especially, where we must remember, I mean it sounds obvious now, but at that time we were getting excellent valve areas and we thought it would be good. But we realized that as the child grows, it doesn't grow. And so we electively started widening the root. It gives you excellent gradients, and we've generally been having excellent. The one thing that you have to remember about Nozaki is the immediate gradient may be looking slightly high. By the third month, you'll have a dramatic reduction, and the gradients are typically single gradient. Even if you get a gradient high, keep quiet, wait, and by the third, and this is something which Ozaki himself has seen in this. And I probably related to, especially in AS patients, where immediately after that you get very high ejection, contraction, and giving falsely high gradients, and also I think the things remodel, and the leaflets also adjust around, and we get an excellent gradient. And we have had a consistent improvement in functional class, as can be seen. This represents around 278 cases which we have done. And this is the survival function. It's been a very good thing, and we have done this data is up to 100 months of follow, and it has been consistent with other valve replacement options. And one of the things that we have had deaths is we need these are that of those who have survived. One of the things which we learned is initially when we started doing Ozakis, our pediatricians were very enthusiastic, and then they started sending us football hearts, and we also this thing. So we realized when not to, and I'll be touching on that, when not to offer this operation. But the important thing that you have to tell is that these patients are at a higher risk for endocarditis, and this has been my experience even with aortic valve repair. Somehow aortic valve repairs and Ozaki are having a higher incidence of endocarditis. So you have to educate your patient to be careful and avoid situations where they could get endocarditis. And we've had a varied mix of patients with these patients over time. And among the patients whom we have done 2 redo Ozaki procedures, and these were for endocarditis, and some of them have been progressing for a year. And actually an interesting thing is that 2 children, we've been able to actually do a balloon valvotomy and delay the thing, because what had happened is that the valve was functioning well, but there was relative stenosis. But because this has got a fairly large amount of tissue coaptation, when we ballooned the child, we could delay the surgery. I mean, that one of the children has become an adult now, and we're going to go ahead with the replacement shortly, I think. But this is something which can also be done in these patients. And another thing that we did, this was at a time when one of my students said this thing, you see, when we were offered this, we were going very aggressive, doing homografts and this thing with double valve procedures with the homographed mitral valve. But then what happened is, when we analyzed why patients were dying, we found that if we have an LVAD D or S with a Z-score of more than +7, and these were football hearts, but they were not being offered surgery, and now suddenly we were giving them an operation, they were enthusiastic. But then I said no. When we analyzed, we found that all of these patients died either perioperatively or within the next 1 year. And then we said, no, if you want to do anything, cannot be conventional cardiac surgery. These are the patients who should be going for transplant, let's not offer them. And we had a significant reduction in mortality after we instituted this. These patients should go for mechanical assist or transplantation. They shouldn't be really offered conventional cardiac surgery at these levels of Z. And we have done a wide variety of things. For example, we've done reduction aortoplasties in children. We have done pierce meshing the aorta. You can see we've meshed the root and you can mesh the aorta to prevent dilatation in some of these cases, especially when we have done it for irreparable bicuspid aortic valves and other cases like that. So we have done the whole gamut, be it bicuspid, unicuspid, and we tend to make all the three leaflets equal because we found that it's better hemodynamics and this thing. So it requires shifting of the commissure. Another thing is in bicuspid aortic valves, depending upon the orientation, you may have to readjust and make neo-commissures not like the original ones. That's an important thing. Then as I said, see, we have been doing either a Manujian or a Yang widening, especially in children, because if you operate a 6-year-old child or a 7-year-old child, you'll get excellent results at that time. But teenage growth spurt comes and you run into problems. So you want to minimize the number of surgeries that this child is wedded to you, like it or not. So we are going to have to do some surgery. And we found that these children who had excellent valve areas, when they started growing up, we had to go in and redo those things, not because the leaflet was not okay, but because there was relative aortic stenosis. Some of these we ballooned, but not everyone could. So we decided every child will at least get it to 19 Hagar should go in, and so we started doing that on a routine basis in those who are not repairable. And we have done a lot of wide variety. For example, here you can see we have done an Ozaki here and put replaced the ascending aorta, Ozaki wheat if you want to call it. And then we have done even porcelain aortas which were unclampable, and we have done endarterectomy of the calcium and done an Ozaki with this. See, you must realize that many people will ask, why not a biprosthetic valve? I'm working in a center where in our governmental schemes, a biprosthetic valve is just not given. So I either have to put a mechanical valve, and for example, if I put in maybe a 60-year-old person, if I put this, he'll have to be committed to anticoagulation. So this is a very cheap option and it gives you excellent results, especially elderly. The degeneration is very low and it's good. And so you can see we've removed calcium. Here you can see all sorts of stuff have been done. Interestingly, see, this is another case which we reported. This was a child whom we had operated, doing well, goes to his village in Chitradurga, which is a brucella endemic area, plays with the calf, newborn calf, and develops brucella endocarditis 3 years after surgery. We went back in, we had a hell of a time, we had to give him antibiotics, give the thing, and he was sick and this thing, and then ultimately we did the redo Ozaki. We did it with donor pericardium, and we did a redo Ozaki, and he's doing well now. The another thing that we do, and in the Indian context, I don't know, we stopped using felt pledgets. Ozaki uses felt pledget. What we found out was that actually in those who had endocarditis, the felt pledget became the focus. Even in this, he had sinuses which were burrowing in and all that, so we had to patch all those things. The felt pledget had got infected and eroded into the aorta, forming pseudoaneurysms. We had to take it out, and this is a young kid, say 7 years old, 8 years old at the time of surgery. You're not wanting to do a Bental for him. And so we just patched all those abscesses and excised, did all that sort of stuff, and gave him a root, neo root, which was all patched. The holes were patched, and did a Ozaki. So we stopped using felt pledgets, but we kept pericardial pledgets. And that one cause came down after that. That was a bitter lesson to learn. And we have used it even in the pulmonary valve. You can see here we were using Binoculus, Nunn and homografts, but we have also been using for tricuspid endocarditis especially. You can see there we have used it in the pulmonary side also. Works excellently. We get excellent results with that. And this is an interesting case, for example, where we had a patient with VSD and infected with VSD, AR and pulmonary and aortic endocarditis, and we did double Ozaki of both of the pulmonary and the thing, and doing very well. Little tiresome putting 6 leaflets in, but boring. It started becoming boring, but doable, and it can be done. And using autologous, so you can see both the valve leaflets. You can see perforation there, and this is. So I've already put up. This is the 100 this thing, and this is what is the data for the those who are younger than 20. It will be vitiated as the child grows up, and we initially did more of adults and then progressed down. So the follow-up is a little. As we became more and more confident, we started offering more and more children. So this is the way it is. It is good. This thing, freedom from death or a subsequent AVR, and these are our publications which we have done with the Brucella one, then compared, then our anesthesiologists have done this thing, and we've done it just to show that you can do it in all forms. And this was at a time when we were not very sure how we can extend it to various things. Today I think we are all doing it. And so what were the points? Don't take patients with the Z value of more than +7. It doesn't work. We made our indigenous sizes. If anyone wants to do this thing, I can give you the STL file, you can print it. Myocardial protection is very, very important, and we stopped. See, many of these patients were sick hearts with LV, AS with LV dysfunction or AR with LV dysfunction. So we stopped using Delnido for these patients and started using St. Thomas cooling, and we started using pericardial dissing because 3 cases, as I said, we had endocarditis with the focus being settling, and see, I don't know why it seeds onto that. The child, it's not that it was early endocarditis or something. These are months, and I told you the Brucella one was 3 years later, but when they get infected, the pledget became the seeding source. Very funny, we use pledgets in other surgeries, but in Ozaki this seems to have a predilection. And we say that it has got good long-term outcomes. You have to be selective. I would say that in a child who can get a repair done, for example, if it's a bicuspid aortic valve, repair the valve. Don't try to do an Ozaki because it is committing to another surgery sometime in future. One of the things is it gives excellent hemodynamics, and the procedure can be done with, you can see a wide variety of these things. In fact, one of our largest groups is to do a triple valve repair. Thank you very much. Yeah. There.
Well, thank you, Dr. Prasanna. What a great pleasure. Of course, as far as I'm concerned, we are concerned, you're preaching to the converted. But it is a great pleasure to hear your talk and to promote this. We're using the word Ozaki, but I'm sure Ozaki will not like
Oh yes,
it.
he won't agree.
Yeah, so
no publication, he objects if we use
exactly,
it.
Exactly.
So I always call it modified Ozaki everywhere.
Yes,
when
yes.
We have always
or just pericardial reconstruction. Two things. Our experience with the infective endocarditis, nearly all the patients have come back who've either had infective endocarditis, or the other problem we have had is recurrent rheumatic activity. Somehow, it's very difficult to prove that that is the cause, but there has been rheumatic activity. That's
so to answer you this question, some of the redos which we have had to do were not related to the, for example, if you do a double valve, and
yes.
We have had the problem with the mitral valve,
yes.
and not the Ozaki will be fine, but the mitral valve has gone down and with rheumatic activity. That's
yes.
been an issue.
We've had
but the Ozaki per se was okay.
Yes. My question, would be, in your opinion, what do you think is the limiting factor for long term? It would be, do you think it is basically the material? In which case, so long as you're doing a good job, whether you use this template, that template, we have our own technique of doing it. That's another story.
I think it's the material.
It's the material, right?
It is
so I'm glad you agree with that.
Yeah.
Ultimately, it's the material.
Yes. And we cannot, see, let's assume, see, at the end of the day, we may call it anything, but it's equivalent to a biprosthetic valve which is going in. It may be autologous. The thing that we do is and we are trying to be better on it, is we are aldehyde capping using protamine as our aldehyde capper. So because I discussed it with Dr. Robert Frater, who passed away recently. So what we do is we aldehyde cap the and we were initially treating it for a longer period of time. We have progressively come down in it, and we are now doing it between 6 and 8 minutes. We don't see, the problem is to do practical aldehyde capping. The only thing which we could do in our setup is, on a practical way for most surgeons, is to cap it with protamine and then secondarily bind it with heparin. That is what we are doing. If we could get another thing which I am thinking of doing is actually defatting the thing with 80% isopropyl alcohol, which I haven't done, but I am thinking of doing that, because these are the things which can promote degeneration and calcification, which could be done on a real-time basis.
Sir, can you just elaborate a little bit more on this protamine? Because what we use is the same solution that our bioprosthesis comes.
Yeah, so that is glutaraldehyde.
Yeah.
But when you treat it, you'll have free moieties which need to be capped, like what Resilia yesterday this one was talking. No, well, Lalit was saying, what is a practical basis for practical thing for us to cap is that you can use protamine. So now you have treated it with glutaraldehyde. Now put it into protamine till you use it. Then wash it and you put heparin on it. So now you have a bond. The protamine goes and gets bound to the free glutaraldehyde open residues, aldehyde residues, because it's a chemical reaction. It binds to that. And secondarily, the heparin can bind again to it, and that acts as a local thing. Just like, but that is not a covalent bond. That's an ionic bond. This bond is a covalent bond between glutaraldehyde and protamine. This was actually described in the 80s, if you go back to the original article. So I had taken out those articles. I was searching for something to bind, and something which is non-toxic. Toluidine blue and all are carcinogenic, and I can't use toluidine blue and other things. And getting surfactants sterile was not a possibility for me. So those were things, the practical thing that was available, which is there in every OT, is protamine. So I aldehyde capped it with protamine. Concentrated protamine, dunk it into the regular protamine. You don't have much time, right? You can't keep it for 24 hours and all. So you can cap as much as possible. It's not ideal, but that's the best you can do in our setup.
Sir, excellent presentation as always. I don't personally do Ozaki's, but I have some questions which may be ignorant, maybe. I saw one of your pie charts where the post-operative NYHA classification, functional classification was NYHA 3 in 80% of patients?
No, that was the pre-operative.
Okay. So my question was based on Bashi sir's experience yesterday. He was mentioning about the pericardium, untreated pericardium being really soft and pliable over many years. Can't untreated pericardium be used?
I toyed with that, but then what has happened is that is being used as a patch, whereas here you need some amount of structure, because all these stories have been, most of these stories we are just, let's be honest, even the Ozaki is something which Lauer and Schumweber had already done. And there they showed many years back, Lauer I think and Schumweber had shown that using untreated pericardium causes tears in the aortic position. So if it is used as a patch, it is something different. But if it is used as a part of the valve, they used to do these things. In fact, I think one of Lewis or somebody had a device where you could place it in and turn, and it would cut the leaflets, and you could implant, and there was a holder and you could implant. See, these are all various things which were done. All these things, history has, we call today Ozaki as this thing, but they have been done before. And the lessons of the past was that don't use untreated pericardium in the aortic position.
And also in your survival...
In the valvular position. For example, as a patch and other things, even in the patch, in the high pressure VSD, though people are using VSD, there have been reports of aneurysms in the patch, but people still use it. good to use as a, in fact, untreated pericardium otherwise as a patch works excellently well. But when it's on the high pressure areas like this, may not be a good option.
And the survival curve that you showed,
Yeah.
I think it was 78% in
around.
about 60 months?
No, 100 months.
Okay.
We don't have, that is 100 months.
Survival.
Yeah.
Okay. And how does that compare
And
to a traditional bioprosthetic one?
It is equivalent for those ages. See, a 20-year-old, would you really, in a child, where would you be able to get that sort of thing? This is, you saw a large volume of our children, and this is survival plus AVR.
Prasanna, excellent presentation. I thoroughly enjoyed it. I agree with you fully that the pericardium has to be treated in order to put it under hemodynamic stress.
Can you put the mic?
I fully agree with you.
No.
I fully agree with you that the pericardium has to be treated if it is put in a hemodynamic stress. And one of the modality of treating the pericardium is obviously glutaraldehyde, which will do a covalent bonding and collagen linkages, which will give the strength to the pericardium. But the problem with that is that you will have a free aldehyde, which will have a propensity to form components with calcium carbonate,
Calcify.
and it will calcify. Now, have you tried any other compound, for example, an epoxy compound, which is
I did
ethylene
not have
glycol?
access to it. If you have access, I would be ready to try.
Yeah, we have access to
Then
that.
I would-
Ethylene glycol, diacetyl ether, which is the epoxy compound.
Yeah, I did not
and
have access to
non-aldehyde.
sterile. I searched for those times. At that time when I started, I did not get access to sterile this thing. In fact, I tried
Epoxy
contacting
compound.
companies, and none of them were ready to give me medical grade sterile this thing. Glutaraldehyde is
The second point is that, as we know, that the glutaraldehyde has a very high propensity to calcify over a period of time.
Yes.
So, have you dabbled into the area of treating glutaraldehyde with, let's say, diphosphonate compound, 0.25?
Yeah, I have not
Which
done
is
that.
a
See, I told you
anti-calcium
the
treatment
way
with
we
most
did
of the
it was
bioprosthetic valves.
the way we did it was to bind it with the protamine and capping it with protamine, which was what we are doing. Actually, I do this. If you can give me the access to.
Sorry to be interrupting. We can take it after the session.
Yeah. Okay, thank you.
Thank you, sir. I would like to call upon Dr. Shrirup Chatterjee, sir, to kindly moderate the session. I now request Dr. C.S. Remat, sir, Junior Vice President ICTS, Director of Heart Valve Bank, Senior Consultant, Shri Madhusudan Sai Institute of Medical Sciences and Research, Bangalore, to share his experience on aortic root enlargement.
Good morning. At the outset, let me thank Dr. Satyajit Bose, the Senior Vice President of ICTS, and his entire team for inviting me to deliver this talk. Well, I have some disclosures. Of course, the audience consists of post-graduates, early career, mid-career, and senior surgeons. For the benefit of the first two groups, we'll expound the rationale and the need of this. Intend to cover pitfalls, tips and tricks in the next few slides. We'll share personal experience with root enlargement. Hope to leave all of you with some take-home message from my presentation. Let's begin. Well, quantifying the small aortic root, as described by Rahimtullah, it's mainly because of obstruction of the left ventricular outflow tract and also stenosis of the ventricular aortic junction, and the causative factors is brought about patient process mismatch. Size of the process is inserted in a small annulus, and of course the reduction in the effective orifice area. Is root enlargement worth the effort is a question always asked, and as you see, the opinion differs from surgeons to surgeon. And even there are a number of surgeons who end up seating a small aortic valve size, which definitely makes a difference in the long-term follow-up of these cases. And anything less than 0.85 centimeter square per meter square area causes PPM. And in that, we further classify between 0.65 to 0.85 is moderate and less than 0.65 is severe PPM. Well, this is a landmark article by Pibot et al. I think most of us know, and these are all the valves which are FDA approved, and they have their reference values of effective orifice areas for different sizes. And the most commonly used valves, if you observe here, is the St. Jude valves across the globe and also the Onyx valves. And if you see here, today, currently, and even after so many years, we do find the Onyx valve with a better effective orifice area in the mechanical processes. The sequelae of the small aortic root, like abnormally high gradients, this is where we go before we plan our cases, and we do measure the effective orifice areas to the reference orifice areas, and based on these criteria, we do plan our surgeries whether there will be patient processes mismatch in that patient. I would always recommend all the surgeons to have this chart in their operation theatres. This is a standard chart been published in one of the journals, wherein irrespective of any valve, based on these sizes, the effective orifice area for that particular body surface area matches, including TT Kichitra valve or other Indian made companies valve or any of the other valves. So anything which falls in the green chart is acceptable. Anything falls in the red chart is not acceptable, which definitely causes patient process mismatch. And yellow is a controversy where we need to look into. Now, what is the sequelae if we don't address this problem? Less regression of left ventricular hypertrophy, less recovery of coronary flow reserve, less regression of mitral regurgitation, less improvement in function class, exercise capacity, increased incidence of late cardiac events, increased incidence of bioprosthetic structural valve dysfunction when we do root enlargement in a bioprosthetic valve, negative impact on short and long-term survival, LV dysfunction, and incidence of arrhythmogenicity always persists. So these are the prerogatives where reduced post-op gradients across the rigid orifice, or if you do see a 4C demand overwhelming the supply orifice area, and also we do anticipate PPM or reduce afterload LVH. This is a comparative diagram I show most of the times when we don't address this patient processes mismatch with an effective orifice area of less than 0.85 centimeter square. Coming to the anatomic route, last almost 24 hours we have been quite clear on the anatomic route. I will not stress on this. For the youngsters, this diagram is very important. Even in the examinations, we do ask them to draw these diagrams, and invariably you have a case, a question on aortic stenosis, root enlargements. Invariably you do have. If not, you miss in the theory. Practically, when you get a case of aortic stenosis, the examiners do ask this question, and this is the relationships from the aorta to the subaortic areas, what are the relationships and where do we cut, because the entire root enlargement is based on this diagram. This was a courtesy by Dr. Robert Anderson, who helped me to understand much more better the atrioventricular arterial complex, which makes much more clarity while enlarging the root of different types. Well, there are different types of root enlargement procedures, and this is an examination question wherein we ask, and here we do have the posterior approach commonly done by most of the surgeons, the newest Manujian-Seibold technique, and the recently added Boyang technique to the armamentarium. And of course, anterior root approaches are different, that is Kona-Rastan, anterior aortoventriculoplasty, the UHE procedures. Many people are not aware, the Ross-Kono, where we happen to do in pediatric cases. Combined techniques, that is both anterior and posterior root enlargements, what is called as Otaki procedure, and myotomy, that is the Morris procedure what we do. And when all these fails, we do get off late, redo root enlargement procedures. And that is the technique wherein we need to look into what else can be done even after doing the minimum root enlargement, because most of the surgeons end up doing the smaller procedures or a simple procedure called as Nix and Nuez. The patient do have increased gradient, patient symptoms are still in NYHA class 2 or 3. they do come to redo procedures of root enlargements. That time we have alternatives, strategies like LV to descending thoracic aorta valve conduit and left ventricular apex to the ascending aorta valve conduit, and of course we end up having a heart transplantation. Well, I will just go through this. These are the common standard protocols what we follow. The Marugian Siebold Eptic technique, which we commonly do in our routine procedures, helps us to enlarge at least 2 sizes of the, we can go up by 2 sizes for the valve, which is the nick between the LCC and NCC going to midpoint of AML, and sometimes just 3 to 4 millimeters from the free margin of the AML. So that's the procedure what we follow. These are few pictorial diagrams what we see. And the commonly used materials are, in fact, I end up using only the untreated pericardium. In fact, we don't even treat pericardium. And when we go back in a redo for any of such cases, it's difficult to differentiate which is aorta and which is the pericardium. It is so well seated most of the times. Of course, other Dacron and Gore-Tex patches can be used. And this is how, and I have a small video also to showcase these procedures. I will come to that. NICS is a very simple, wherein it may increase by a single size aortic valve compared to the Manugian procedures. And it's a where NIC we make in the center of the NCC up to just up short of the annulus. And that's the procedure what we normally do it in if you want a single size enlargement of the root. And coming to the newest procedures, it is between the NCC and LCC and falls short of the mitral annulus. We don't go into the mitral annulus or go beyond into the AML. That's where we end up having a newest procedure. This also may increase by 1 size, or sometimes we can push in a 2 size valve. Coming to the Konarasam procedures, this is a part of the anterior root enlargement. Definitely we can go up by 2 sizes, and of course technically a little much more demanding when one has to be cautious, wherein you make a nick, the cut opening between the to the right of the to the left of the right coronary ostium and go into the interventricular septum. You create an iatrogenic VSD, and the VSD is being closed by a separate patch followed by a right ventricular outflow tract, a separate patch, causing an anterior root enlargement procedures. These are all self-explanatory diagrams wherein we can understand and plan accordingly. Sometimes we can use the same patch buttressing on the LVOTO and use it, one for the VSD closure and one for creating the RVOT patch. Sometimes we take 3 separate patches for the VSD and for the closure of the left ventricular outflow tract and also for the RVOT patch. If pericardium is not adequate, then definitely we can use, as I mentioned, either Gore-Tex or a Dacron graft can be used. Coming to Ross Cono, commonly done in children procedure, wherein it is a modified conotype enlargement. We use the autograft for AVR in children, and of course the right ventricular outflow tract can be further taken care by using a pulmonary homograft. And the advantage of this is the valve grows along with the child. That's a big advantage when doing Ross. But Ross, as we know, many people, it's not everybody's cup of tea, wherein it has its own challenges. But once it is, I think, mastered, I think Ross should be a doable procedure, especially in children, rather than going for a root enlargement and a valve replacement in a child. These are self-depicting diagrams which helps us to see the Ross and the Ross Cono procedures. Now coming to modified Cono procedures, wherein subventricular left ventricular outflow tract is augmented using the patch and also for the VSD also. We do plan. Sometimes we do happen to do the both anterior and posterior root enlargements, which I will come to that, which can increase a valve size by almost 3 to 4. I still remember operating a case wherein a 30-year-old lady with 14 annulus ended up doing anterior and posterior root enlargements, ended up putting a 23 valve with very good LV regression and a follow-up of 12 years plus. So there are cases wherein we have to be a little aggressive in these cases to give an adequate LV outflow tract, so that the regression does take place of the LV and has a really near normal life, I would mention it rather, or in class 1. Coming to LV to aorta conduit, these can be planned especially in a redo aortic root enlargements or when none of the procedures work. That time these can be attempted, and either from the apex to the descending thoracic aorta or from the apex of the ventricle to the ascending thoracic aorta, the ascending aorta can be planned in a reduce root enlargement procedures. We do get valve conduits nowadays, wherein especially those valve conduits can be utilized for these procedures. The newest kid in the block is the Boyang technique procedure, wherein we all know the incision is same as that of the Manoogian, but he extends like an inverted Y into the annulus of the mitral valve. So here also we can go up by 2 sizes or 3 sizes, and one disadvantage is impingement of the left coronary artery. That can happen in these procedures. One has to be careful. Otherwise, the incision is more or less into like the Manoogian procedure. Only thing, it does not enter into the AML. He goes into the annulus of the mitral valve. Now, extrapolations following these root enlargements. What are the newer innovations? What the surgeons thought about it was, after root enlargement procedures, the Ross-Cono came into picture. The command operation came into picture, wherein command operation is a surgery where you can enlarge the mitral annulus also. So it's quite challenging procedures where simultaneously an aortic and mitral root enlargements can be done. Root in the annulus can be enlarged. Especially putting a mitral valve annulus of 23 size is quite may not help much in the entire procedures. Of course, very few surgeons do this. Ross-Cono switch operations came into picture, and aortic root translocation, that is Beck's-Nakaido. All these were extrapolations of root enlargement procedures. Now, how I do it? These are things which I would like to say. Normally, the most commonest one is done is the Manoogian Seabold lifting technique, wherein I use an untreated pericardium going into almost up to the midpoint of the AML. This is how I normally put a patch, wherein I do not keep it as a diamond shape. The classic textbook picture is make it a diamond shape while doing a Manoogian procedure. I keep it a horizontal patch itself and start at the midpoint of that horizontal patch into the apex of the AML and start suturing as it comes above. The same patch is used to cover the aorta also. And of course, the valve seats at an angle of about 30 to 45 degrees. It does not seat flat horizontally. 30 to 45 degrees it seats, and the opening closing angle of course does vary, and invariably post procedure the anesthetist finds difficult to align with the LVOTO, and they end up giving you a false gradient most of the times. But you as a surgeon have to be clear in what you are doing, and whatever gradient they do tell, it ends up being false, and they do agree that, some of the good anesthetists do agree that they are unable to align because it is seated at around 30 to 45 degrees. Most of the times we use bileaflet valves, and in many cases I use the TTK Chitra valve also. So this is where, as I mentioned, we happen to do a Manoogian and Cono procedure with a valve annulus of 14, end up putting a 23 valve, and that is the enlargement what we can do sometimes. So this is the Cono and the RV valve, where we end up using 3 patches. One is in the posterior root enlargement for the Manoogian, and anterior root enlargement for Cono Rasan, where the one patch closes the part of the LVOTO and another patch closes part of the right ventricular tract, and one more patch, the same patch can be used to close the iatrogenic created VSD. This is a small video how I do it. It's just 2 minutes video. As you see, I use untreated pericardium of the patients invariably, and based on the requirement of root enlargement, we do the video is not running. Can somebody help me? Yeah, it started. Yeah. But take another few minutes. The one thing what we see in these root enlargement procedures, you can't, again, the bleeding has to be planned properly. I use a 5O 11 mm, that is easy pass black color needle, wherein we do a double suturing and use the first pericardial pledget itself at the base, because this cannot be addressed again once you are off bypass. If you want to address any bleeding point here, you have to go back on bypass, clamp the heart, and then only retract. Because the more you retract, the more it starts leaking or starts ending up rupturing. That's one thing we have to do, because there is no second chance in these procedures, what I normally teach my students also. So that's how we plan and seat the procedure. That's a large pericardium seated there. And sometimes we may need not open the LA. We can just dissect the LA from the aorta. Sometimes we do open the LA, and when you open the LA roof of the LA, that time we need to put an additional patch on the LA roof. Without opening the LA roof, we can end up going up to into the AML. That's the standard. This is St. Jude valve what we have taken and planned accordingly. And this is a pre-operative plan itself. It's not that on table you take a decision of doing a root enlargement is very unlikely. You plan yourself well and so that the adequate sized valves are available. And in this seating procedures, as I told you, it seats at around 30 to 45 degrees angle. The RCA and the LCA has to be taken care so that they do not impinge on that. And rest of the procedure is same, and with another 5 suture you end up closing the aorta. And this is important because you have created a neo-sinus, and that additional patch gives better hemodynamics in the post-operative period because we don't have any special sinus. We have actually destroyed the normal anatomical sinus. So this gives an additional sort of a sinus formation for adequate hemodynamics to avoid any paravalvular leaks and all. Coming to my personal experience, this was published way back in 2022 in the Journal of Cardiac Surgery, from wherein we had close to around 10 years follow-up patients of 65 cases what were done, with initially starting off with a peak gradient of 60 plus or minus 32 and valve area as mentioned. Diagnosed to be possessing inadequate LVOT annulus, T assessments were all planned, and final decision was on the table with whatever adequate required left ventricular diastolic pressure and the peak gradients. The common valves used, as I mentioned here, was Chitra valve, 34 cases, and Medtronic ATS in 2, St. Jude's in 16, Merrill Daffodil valve in 2, and Carpenter Edwards in 1 case. And the technique employed, maximum wear Manoogian Seabold lifting technique 34 cases, Kono Manoogian Seabold lifting technique in 2, that is both anterior and posterior root enlargements, Newes in 12, Nix in 7. The gradient follow-up were as follows. Even after 12 months, the gradient was almost less than 10. And they are in a follow-up of almost close to around 12 years till date. In fact, the internal effective orifice areas also, as mentioned, is quite adequate and acceptable. The LV mass index in the post-operative follow-up period, you see the LV mass index regresses, and this is very evident how the patient slowly becomes asymptomatic, or at least in NYHA class 1. That is very important, and in 12 months follow-up you see that patients who were in NYHA class 3 we had come down to almost to NYHA class 1. Freedom from all-cause mortality was almost around 90.9%. We had 2 cases in this. I lost 2 cases. One was because of malignant arrhythmias. One more thing, in hypertrophied LV, I think even Dr. Bashi and all, everybody agrees here, wherein once arrhythmia sets in an hypertrophied ventricle, it's very difficult to revive it. Even if it revives in the post-op, again we do have a challenge. So best is to prevent arrhythmias, and one has to be very careful. And I did have one malignant arrhythmia which could not be revived. And of course, another case went to low cardiac output syndromes and ended up losing 2 cases. This was the data up to 2022. Followed by that, I have done around 11 cases using the newly introduced Miltonia valve, also 2 cases in double valve root enlargement procedures. That needs to be added. To summarize, yes, the question asked to me was, is root enlargement absolute? Yes, it is an absolute to no. And aortic root enlargement in aortic valve replacement must be done without a second thought if indicated. Indication for aortic root enlargement is a surgeon-centric now more than ever. It allows the insertion of an approach site prosthesis in patients with a small aortic annulus. Must know to mitigate patient processes mismatch. Performed properly by an experienced surgeon, the technique is safe and reproducible. I thank Dr. Sampath Kumar, the ex-HOD of All India Institute, who has trained Satyasai students. And in his article, he mentioned way back in 1984 that for root enlargement procedures, those surgeons who consciously ignore good practice standards must deserve the utmost professional disrespect and condemnation. And that is important, and that's very important in all our day-to-day activities. I think with this, I would like to conclude. Thank you so much. This is my new institute where I have joined. I request all of you to come and spend some time here. We have our past presidents, Dr. Manoj, present President Devaguru, the sitting senior vice president visiting our institutes. I request everybody to just drop in some time and do spend some time in the institute where we are doing the human service in the world. Thanks so much once again. I'm happy to take any questions. I'm late.
interest of time, we'll go forward.
Yes, sir.
Any questions we can have?
Done. Thank you, sir. Thank you, sir.
Thank you very much.
Thank you, sir. Now I invite Dr. Praveen R, Senior Consultant CTVS, Narayana Hrudayalaya, Bangalore, to deliver a talk on Ross procedure.
I would like to thank Dr. Bose, Dr. Chatterjee, my mentors, for giving me an opportunity today. Thank you. Yeah.
Okay. This is about laser front.
This is?
Forwarded.
Okay.
This is laser.
Oh, this is forwarding, no?
Yes.
Yeah, my topic is Ross procedure in the present day practice. So as we all know that Ross procedure is a disease wherein we replace the diseased aortic valve with the patient's own normal pulmonary valve. And in place of pulmonary valve, we put a pulmonary homograft. So before going into procedure, I'd like to know that what are the outcomes of Ross. So if you can see that there are systemic reviews, meta-analysis which showed that 99 publications and with early mortality risk of around 4.19% and late mortality of 0.5%. The autograft reintervention rates are 1.28 and RVOT reinterventions are 1.97. The estimated life expectancy, which is important here, which is 59 years. The general population is 64 years. There is one more article by More et al. Which says in children that around 30 studies they have studied and the median follow-up was 5.7 years. So they have found that the early mortality was high because of increase in neonates. And the late mortality, it's around 0 to 1.8% per year. And the reoperation rates of the autograft were up to 2.8% per year. So we have published about 22 years data in our single center institute at Narayana. We have done around 258 cases in last 20 years. And most of our patients are in the range of around less than 20 years of age. So as you can see that at 20 years follow-up, the freedom from all-cause mortality is around 90%, and freedom from cardiac mortality is 98%, and freedom from moderate to severe AR is 84.5%. So here you can see that we thought it could be like, these patients will have more complications over a period of time, 5, 10 years, 15 years, 20 years. But when we analyzed the data, we saw that these patients are doing really well at 20 years of age. So in conclusion, what we said, there has to be some modification which have to be done, because in cases of severe AR, aortic root which is dilated, this autograft dysfunction is more. So we have to make some adjustments with the technique of doing the Ross procedure. So what kind of conduits do we use for Ross? The gold standard is the homograft. When we don't have homografts, we have some other techniques like, we can do a bovine pericardial tube conduit with a PTFE valve, or a Dacron graft with a PTFE membrane valve, or a PTFE graft with a PTFE valve. This is the homograft. It looks as normal as the patient's own pulmonary valve. This is the Dacron graft with a PTFE valve in situ. Here you can see that the valve coaptation, this is basically like an Ozaki technique, what we do, we recreate the PTFE leaflet according to the size of the graft what we use. This is wherein we, for small children, like, if we have to put a conduit of say 14, 16 size, tricuspid valve conduits are not good because they have an innate gradient inside them. So what we do is we use a bicuspidization with the PTFE valve in the pericardium. And this is the PTFE valve with PTFE conduit. So let me start with Ross procedure in children, where I'm going to show this a 2-year-old child with bicuspid aortic valve. At 6 months they did a balloon valvotomy, and again it came back with severe AS and AR. So this is surgical video where we cannulate the patient, standard bicannulation, then we open the pulmonary artery and see for the pulmonary valve. Once the valve is analyzed, then we put a cross clamp, do a aortotomy, give cardioplegia. We can use topical ice slush. So this is how we harvest the autograft. We have to go at least 5 millimeters below the pulmonary annulus with a sharp incision. The scissors you cut across the RVOT. Now here, just below the pulmonary annulus, make a incision with the 15 number blade and with sharp dissection at an angle oblique, so that we don't injure the first septals or any branches of the coronaries which are there. So this is the area where we have to take a little bit of care so that we don't damage the left main or its branches. We can use cautery also, but I would prefer not to use cautery at the septal area. Then we put cardioplegia and C into the left coronary. If there is any bleeding, you can just take a few bites on the coronary or small branches which are bleeding. Then we harvest the coronaries, buttons. This is the right coronary button. You don't need to mobilize too much for Ross procedure. So then the leaflets are excised. Then you start suturing the autograft into the aortic annulus. There are different techniques. I learned it from Dr. Chatterjee. I use a single 5-oprolin suture or 4-oprolin suture and a continuous bites I take. Sometimes I use a pleasure in between just for hemostasis, but one layer of suturing is more than, I haven't had that kind of bleeding, but it's more than sufficient. But if you are worried, you can always take a second layer of suturing onto the the muscle which is around the aortic annulus, the autograft annulus. We have to be careful with, when you're taking these bites, you have to be careful with not injuring the aortic leaflets, because it's a collapsed conduit. The leaflets just, they get stuck to the conduit, and then you can, when you're taking, it might, so we see for the valve competency after that with saline testing. And these coronary buttons, we make a punch hole in the autograft at the appropriate site. And with 5 or 6 depending upon the thickness of the button, you can use either 5 or 6 and do the anastomosis. This is the left one. This is the right coronary button. Then you do a distal anastomosis of the RV2PA conduit. I usually prefer to enlarge the pulmonary artery towards the left side so that we can fit in a bigger size RV2PA conduit in this. Then the aortic closure, either single layer or double layer, depending upon your comfort. Then this RV2PA conduit is sized. We just bevel the conduit at the appropriate site. Use a pericardium as a felt just to give an extra, strength for the anastomosis. Nowadays I use a pericardium at the bare area, what we saw, the autograft which has been harvested, so that whatever strength we can give it to the RV conduit, that will come from the pericardium. Then see for the coronary flows after that. So why did we come with modified ROS? So there were problems with the ROS procedure. They were thinking this was causing lot of late autograft dilatation and new aortic AR. So the David et al. They said that around 12% of the patients had autograft dilatation at 44 months. Even Lucini in circulation published around 34% of patients had. So the list is all of them had the autograft dilatations. So they were thinking of some other alternative, and they found that there were causes for this autograft dilatation. Causes were mainly, basically it was seen in bicuspid aortic valve patients, patients with dilated aortic ascending aorta, aortic root, if it is a primary aortic regurgitation, or if you are using a surgical technique like root replacement technique, and in younger patients is more common, and female patients. So Ross Angelaider, he described this procedure in 2004. He reinforced the Ross autograft into a straight Dacron tube graft. And in 2006, Terry Carey also explained the same technique, but in a sinus of Valsalva graft with a different coronary button suturing technique. So here what is modified Ross, where they put the autograft inside the conduit and suture the proximal and the distal end to the autograft of the graft which they use is around 1 to 2 size bigger than the autograft size. Terry Carey is the same thing but in the sinus of Valsalva, and his coronary anastomosis technique is different. He makes a hole in that and then suture directly to the native sinuses. So in 2019 he published his midterm and long-term results of 24 patients. So the median follow-up was around 6.5 years. Now experience, he had 5 patients who had required re-interventions and 1 patient with mild aortic root dilatation by 4.1 centimeters. The Stans et al. Also retrospective study of 129 patients. He says that pulmonary autograft re-intervention significantly more in unwrapped patient technique. Even Terry Carey in 16 patients, he said only 1 patient required re-operation. The rest of the cases, there was absence of AR. So with this, even I thought like, let us try and do the modified Ross operation. But somehow like, with the state graft, the Dacron state conduit doesn't have sinuses. And as we know that we cannot, our patients can't afford Valsalva grafts. So I did a modification in this. I created a pseudo neosinuses in the straight Dacron conduit. So in this, we are harvesting the autograft. It's on beating heart so that we can avoid the cross-clamp time. It takes around 15-20 minutes for the autograft to harvest. Then after harvesting this graft, we can prepare the graft. That will take at least another 30 minutes. So around 45 minutes of time is, precious time of cross-clamp is, saved. So once we take out the autograft, we take the 3 sinuses and then place it in the straight graft. Then start suturing the proximal, the lower part of the root conduit to the Dacron graft. 3 sutures and then suture it to the graft in the continuous running fashion. Then this is an important step. We have to suspend the commissures at an appropriate height. This will take a little time. First we have to pull the graft and then fix the commissure, but don't tie the sutures. You just put a rubber short and then after all the 3 commissures are in place, then you check for the aortic valve, how the valve is functioning. All the 3 sinuses. You might have to adjust 1 or 2 millimeters up and down in this case. So then we see that if the leaflets are doing well, then we fix the commissures. All the 3 commissures are fixed and then the sinus part is removed, leaving around 4 to 5 millimeters of the sinus tissue for the suturing of the graft. With the experience of David, so we started doing this. We take a horizontal mattress suture from one commissure to the other commissure. Because this is not a hemostatic suture layer, suturing in the modified Ross, we can just use only one layer in this. So we come up to the next sinus and we have to tie a little harder so that the graft puckers. So this puckering creates this neosinus. As you can see, those 3 neosinuses, 1, 2, 3. So that will help in the cooptation of the leaflets. Yes. So in conclusion, Ross operation definitely has a learning curve, but it can be mastered. Because of the growth potential, it's an excellent choice of operation for children and young adults. Because we are avoiding anticoagulation, it's a right choice for young female patients, children, even adults. Superior outcomes in patient quality of life, especially in athletes and breadwinners. And with the necessary modification of Ross technique, we can avoid long-term autograft dysfunction. Thank you. Yeah. Right.
Well done, Praveen. Thank you. In the interests of, we are running a bit late, but it was an excellent presentation. And I think there'll be more questions about this, but I would certainly say that, again, more Rosses, please. I think it's an important operation, whether we do the beautiful modification that has been shown, But I would certainly say, at least from the previous speaker, Dr. Hiramat, more root enlargements to be done in this country and more Rosses. Okay, thank you. But more discussion, we can have over coffee later on. But let us proceed. Okay, thank you very much.
Thank you, sir.
I request the speakers and chairperson to have a group photograph, please. I request Dr. C.S. Hiramat sir and Prasanna Sima sir to come on stage. Thank you, sir, for chairing the session. Now we move on to the next session, that is thoracoabdominal aortic aneurysm. The chairperson for this session are Dr. Manoj Durairaj, Dr. Hamdulle, Dr. Pradeep R, Dr. Niranjan Hiramat sir. I request the chairperson to kindly chair the session. Dr. Hamdulle sir. I now request Dr. Amol Kumar Boche, Consultant CTVS UAIMS Sangli, to deliver a talk on spinal cord and visceral protection in thoracoabdominal aortic aneurysm repair. Over to you, sir.
Good morning, everyone. I thank both Sir Srikant, Rahul, and the whole Durgapur team for giving me this opportunity. It's often said that we are as young as our spine, or rather, we are as old as our spine. So you can imagine if during the surgery or during the treatment, if patient sustains spinal cord injury, it's the end of life for him. Because it's not just the paraplegia which is the problem here. The whole spine controls the autonomic functions and bladder, bowel, etc. So patients are going to have multiple complications after spinal cord injury. Bladder and bowel control is lost. They are bedridden. Multiple infections like UTI, chest complications, whatnot. So patients succumb to these complications if they suffer the spinal cord injury. So incidence has been varied across the different studies, as minimum as 8% and as maximum as 28%. So there are certain variables which decides the incidence. The most important one is the extent of the repair or the extent of aneurysm. Most common in type 2 followed by type 1 and least in type 4, that is infradiaphragmatic type. So there are certain risk factors. Extent we already discussed. If it is a ruptured aneurysm or dissected aneurysm, then chances are higher because the perfusion is less, perfusion pressure is less. Prolonged aortic cross clamps and sacrifice of the segmental arteries, any segment, thoracic segment, abdominal segment, lumbar segment, etc. So anemia and other comorbidities can contribute to the incidence of this. So we'll go little into the anatomy. So we have one anterior and two posterolateral spinal arteries. So there is a system which is fed by different segmental arteries at different level. It's like a river. When river originates, it's a very small stream which starts, but the other streams over the course, they will feed the river and the river becomes big. The same system is working here. The spinal arteries are smaller to start with, and in fact anterior spinal artery is sometimes discontinuous or it becomes very small in some of the segments. But it is continuously fed by different segments from top to bottom, namely intercostal, posterior intercostal, lumbars and sacral arteries, and at the top it is the vertebral and the costocervical trunk. So this is the picture which shows different feeding areas. So pathophysiology, it is the perfusion pressure of the spinal cord if it gets affected, either due to the decrease in the mean arterial pressure or because of the increase in the hydrostatic pressure of the spinal cord. The perfusion pressure is going to go down and the spine is going to sustain the injury. So we can broadly classify them as immediate and delayed. Immediate is always related to the surgery. When we apply the cross clamp, certain segments of the spine is not going to receive blood. Usually patient wakes up with the dense paraplegia, and this is not having a very good recovery, chances of recovery, because much time has already been spent in the ischemic period. Delayed onset, patient wakes up with the normal limbs, but during the course of treatment in the post-operative ICU, they develop paraparesis or paraplegia. Maybe the reason being hypotension or cord edema, etc., reperfusion injury. These are the contributing factors. If we take enough steps into the post-operative period, this can be prevented, and to some extent it can be reversed. So there are certain preventive strategies: minimize the ischemia time, maintain perfusion, preserve blood supply. They sound similar, but I'll just go into the details of those. So how we can minimize the spinal ischemia time? We have two techniques. First one is a sequential clamping. Earlier days there was a technique, just clamp and cut and sew, which is no more followed. What we follow in today's era is sequential clamping, allowing the spine to adjust its blood supply across the whole network. And second one we have is the shunts, or the continuous perfusion of the distal segment using some kind of technology. So passive shunts are like ioto, femoral shunts, God shunts, etc. And active shunts are like, we'll go into the details of those. So God shunt is basically a proximal to the distal shunt without any intervening pump. So Veliathan sir along with God, they just demonstrated this technique in the aneurysmal surgeries. These are temporary shunts. It is driven by the aortic pressure, and no much of hardware is required for this. So one of my friend at Sri Chitra uses this kind of connectors to make the shunt. So these are the different limbs for intercostal art. This the distal aneurysmal segment, renal artery, SMA, etc., and femoral. So you can see the feeding is taken by the proximal healthy segment and it is put into the femorals. And the side arms can be preserved, can be kept reserved, and they can be used when the ostia of the visceral and renal arteries are available. So they aim at maintaining at least 60 mm of Hg of mean arterial pressure down the line. So passive shunts advantages are it's simple, it is low cost, no need of CPB machine, means high dose of anticoagulation, but there are certain disadvantages. Vessel injury can happen, dislodgement of the plaque can happen, and we need to continuously monitor the pressure in the distal part. Coming to the active shunts, we have left heart bypass. We take the oxygenated blood from left atrium and then put it into femoral artery with some with a pump intervening in between. So this is basically this is the setup when we operate for thoracoabdominal aortic aneurysm. First, the distal segment of the aneurysm is perfused, and once the aneurysm is opened, the individual vessels can be perfused with the side arms. So advantages are it's reliable. We can maintain the pressure with the pressure pump head, and aorta need not be cannulated, especially when it is calcified and diseased. Disadvantages: it requires machine, it's expensive, complexity is there, and we require perfusionist and the other trained staff to maintain this. So we have other options like partial and full cardiopulmonary bypass, that is femoral bypass. We can say it's a lower body bypass. It can be partial or it can be total. If it is just the perfusion of the distal limb, then we can go for partial, maintaining the upper body perfusion by heart's own ejections. So here also perfusionist needs to be very careful regarding the maintenance of both the pressures, that is upper part of the body and lower part of the body. And during the surgery, if there is some modification into the surgical technique for which we want to go ahead with DHCA or we want to shut down the flows, then the full CPV can be instituted by this and we can go on DHCA. So the next strategy is maintain the perfusion pressure. So the perfusion of the spinal cord is the function of two things. One is the mean arterial pressure at the pushing head, and the other one is the spinal cord's own hydrostatic pressure, that is the column pressure. So to increase the perfusion pressure, we can increase the mean pressure or we can decrease the this hydrostatic pressure, CSF pressure. So for that we have lumbar drainage. It is pretty, the general anesthetist can help in this regard, as they are doing this procedure daily. So usually the L4, L5 is pricked, and the epidural catheter is, it's taken into the subarachnoid space of the spinal cord, and usually it is put in the pre-operative period, 1 day before, because anticoagulation related complications are less. So the drainage is usually 10 to 15 ml per hour, not more than 150 ml per day. So the objective is to keep the CSF pressure less than 10. So there are certainly some complications like hematoma, cord injury and meningitis. So there is one meta-analysis and a lot of paper from Koseli et al. Which supported this, and now it is a class 1 indication for type 2 basically. So the third strategy is to preserve or restore the blood supply. So there are two aspects for this. One is to prevent any leak or any steal during the surgery, and the second one is to reattach the supply. So these are the different technique by which we can the intercostal arteries can be reimplanted into the graft. The individual arteries can be implanted. Here you can see they have implanted in 3 patches, or the whole patch can be reimplanted. The down side of this is aneurysmal formation in the future. Or we can use the grafts, side arm grafts. There is always a risk of thrombosis of these grafts and the compromise in the blood supply. So it's controversial. There are 2 schools of thought. The one who don't support the intercostal reimplantation, they say that even in endovascular, the whole of the intercostal arteries are covered, and very less number of people sustain spinal cord injury. And there are aneurysmal formation and other complication when we reimplant the things. And the people who support the reimplantation, they come up with the data which shows that there is decrease in the paraparesis or paraplegia when we reattach it, especially the T9 to T12 segment. So MEP can guide us whether to reimplant or not. And preoperative DSA, MRI or CT scan can show the significant size of the segmental arteries from T9 to T12. If they are present, then it's a better idea to reimplant them. Usually it's the knee level jerk of the assistant to suck whatever blood is coming from the aorta. When we open the thoracic segment of the aorta, a lot of bleeders will be there, which will back bleed. So we should not suck it, because the negative pressure on the sucker will further decrease the mean arterial pressure in the whole of the spinal network. So the technique to handle it is just apply the clips in the upper segment and put some Fogarty's in the lower segment, because you want to reimplant them. And the clip which is applied, you can overrun with the suture later on, because if you just start with the suturing from above downwards, a lot of time will be spent, at least 5 to 10 minutes will be spent on that, and that is a lot of time for the spine. So early detection of spinal hypoperfusion. We have different techniques and technologies. One is SACP, MEP, and the spinal NRARS, which is new thing coming up. So SACP is not used anymore because it is not reliable. It basically measures, it gives the sensory pathways, it assesses the sensory pathways. It is not reliable. The second one is motor evoked potential. the stimulus is given on the cranium and it is measured at two levels. One is at the thumb level and the other one is at the tibialis anterior level. Because the segment which is precarious and which can sustain the maximum injury is in between these two. So when the stimulus is given, if it is equal on the both sides, then we can be sure that spinal cord is functioning. But during our surgery, anytime if the tibialis anterior is not showing any amplitude and only the thumb is showing, it means that somewhere in between these two, somewhere there is a problem, and we need to take necessary steps like increasing the mean arterial pressure or to reimplant, the decision of reimplantation or decision to drain more of CSF fluid. So the MEP can indirectly guide you to take the preventive step in time. So this is spinal NIRS, which is upcoming technology. Nothing much information is available on this because it's evolving technology. So it is similar to the cranial NIRS. They attach two sets of sensors and they measure the saturation of the arterial and venous system across in the tissue which is just surrounding the spine. Coming to the last strategy, that is increasing the tolerance of ischemia. So we have hypothermia and we have drugs. In hypothermia, if we are going for full bypass, then we can go on DHCA or TCA. Or if we are going on a partial bypass, at least 32 will help us. Some authors have tried the local hypothermia, like putting a catheter inside the subarachnoid space and pushing the cold saline, but they are not proven to be much of benefit. And in drugs, the only drug which is proven to be beneficial is methylprednisolone, and others are not much beneficial. One dose preoperatively 500 milligram, and one more dose in the postoperative period. This helps in reducing the spinal cord edema and help in maintaining the spinal cord perfusion pressure. So if I want to put it in all the strategies in one paragraph, so it starts in the pre-op, adequate hydration, pre-operative spinal drainage, adequate study of the anatomy of segmental arteries, and the surgical technique to minimize the clamp time. This is in the pre-operative period. In the intraoperative period, execution of the plan which is made without wasting any time on the clamp, reimplantation of the intercostal arteries, and in the post-operative period, maintaining enough BP, enough mean arterial pressure with enough volume and vasopressors. This is the strategy. So coming to the organ protection, we have got visceral and renal protection here. So the hydration to be maintained for renal, and I'll just go through one thing. The Coselli et al. They studied normothermic blood versus crystalloid solution for the renal protection. They found that crystalloid solution is better than the normothermic blood. Basically, they used mannitol 12.5 grams, 125 milligram of methylprednisolone in 1 liter of cold plasma light. So just give it in the OST at 300 ml each and repeat it after 15 minutes. So basically, this is the setup. So the take-home message is spinal cord ischemia is devastating complication. Prevention is the only strategy. We cannot do much after that. Though the paraplegia is anatomic, the prevention is physiologic. Thank you very much.
Thank you, Dr. Mole. Excellent presentation. We'll take questions at the end of the session, if you don't mind, in the interest of time. Thanks.
Thank you, sir. Now I request Dr. Muhammad Idris, consultant CTVS, SIMS Hospital, Chennai, to deliver a talk on open thoracoabdominal aneurysm repair, technical pearls and pitfalls. Thank you.
Good morning once again. I thank both sir and his team for this opportunity. So thoracoabdominal has 3 different approaches. One is open surgery, total endovascular hybrid. I'll be talking about the open surgery. So this starts about preparing the patient psychologically even before the day of surgery, and from the OPD start preparing them, and in-situ spirometry has to be done, and skin preparation because it's going to be long incision post-operatively and should not get infected. Bowel preparation is a must because you are going to enter the abdominal cavity, so bowel preparation is a must. And all equipments has to be prepared. So lot of blood has to be there, FFP, fresh frozen plasma, and a single donor platelet has to be ready. And you have to have a cell saver in proper place, and all the concentrated factors like factor 7A and prothrombin factors has to be there. And the branch graft, which has made our life easy, should be made available. The sizes, or 3 sizes are available, all should be available. And the anesthetists have a lot of intraoperative monitoring. So everything has to be in place, the double lumen tube and the different sizes, then the pressure monitorings, upper body, lower body pressure monitoring, urinary catheter, and NIRS modding, and the spinal cord monitoring has to be done. We usually put the spinal cord drainage the day previous to the surgery, because in case on the day of the surgery, if they hit the any blood is there in the spinal drainage, then we cannot give heparinitis to the patient, so I have to push the surgery to next day. So do a spinal cord drainage on the previous day and then do it. So these are the complications which you can enter in thoracoabdominal, and this list is endless. There could be a lot of complications, and the best way is to prevent the complications, and when you enter the complications, it's very difficult to come out of these complications. And entering the abdomen, there are 2 entries. One is the extraperitoneal approach, other is intraperitoneal approach. Each has its own advantage and disadvantages. The extraperitoneal approach is like where you divide the diaphragm entirely and cut open, and then reflect, without opening the peritoneum, you just reflect all the organs, intact pericardium towards the right side, enter the abdomen. So the incision is the same, thoracoabdominal incision is there, cut the muscles. Usually we enter by the 5th or 6th space and divide the costoparental junction here, and then mark the diaphragm and completely divide it. So marking stitches are made so that we can attach accordingly, so otherwise it will get easily torn off. So once it is divided, you can see the intact pericardium here. So the entire circumferential division of the diaphragm is there. So that is the disadvantage of this procedure, but the entire abdomen is in place. So entire abdominal cavities are not exposed, and the splenic injury is much less in these patients. Once you expose it, once you get exposed everything, so these are the marking stitches you can see. So similarly, it will be on the chest wall cavity also at the time of closure. So you can approximate at the same color to color match, and then you can complete the procedure, diaphragmatic closure. The second approach is the intraperitoneal approach, where you need not divide the diaphragm. The diaphragm can be divided at around 3 to 4 centimeters at this region, and another around 3 to 4 centimeters at this particular region as well. And you can hook the diaphragm and just pull it out. But during the entire procedure, what happens is that the diaphragm is on the way. You have to retract it towards the upper part and the lower part. So during the anastomosis, that comes in the way. So, but the diaphragm is intact, and the entire part is intact, so that the respiratory problems are much less in this type. But you have to go enter the abdomen, where you have to take care of the spleen and the pancreas. You have to be taking care of it, otherwise you may injure it, and patient may end up in post-operative problems. So you could see here, this is the intraperitoneal approach, where everything is reflected within we enter through the abdomen, and at this point of time what happens is, even if it is a second surgery, it becomes even more difficult. And if the patient has had an abdominal surgery like infrarenal abdominal aneurysm repair, and that point of time when you want to enter, there is no other choice except to go in for the intraperitoneal approach, because the retroperitoneal you cannot be able to reflect. Here you could see the diaphragm is intact, and we'll be looping it and just reflect it either up, depending upon the situation, up and down, and then you can do the procedure. So this is a technique which we have described from our unit, like if you can enter here, if you see retroaortic renal vein, normally the renal vein is anterior, but sometimes when it becomes retroperitoneal, once you reflect it, what happens is that the renal vein comes around this aorta, and it will be very difficult to approach this aorta, and if you injure it and you had it, you won't be able to reimplant it. So that is when we reported this one in the European journal. So instead of going retroperitoneally, we create a plane anterior to the gerontosfacia and approach it, so that the aorta can be approached through this region. and the kidney is towards the posterior abdominal wall, and retroperitoneal, we have done it through the intraperitoneal and the retroperitoneal approach with this technique. So these are the different methods, the surgical options which is available, and side biting clamp, I mean, we can do it, or the most commonly and which we prefer in our unit is the extraperitoneal approach, which is much safe. As a cardiac surgeon, it's always easier. We are usually not dogmatic about what approach we take in. So there are different approaches. One, it can be on pump, total circulatory arrest, where we have to cool the patient. Other is the branch first technique. Other is have a mild hypothermic and have a selective perfusion. This is a 30-year-old female from Maldives, and the exposure is, you could see here. Once the exposure is done, we divide the diaphragm and looping. This is the looping of the left common carotid artery. Between the left common carotid and the left subclavian artery, the aorta is looped. And the preferred approach is femorofemoral cannulation. So once you approach this one, so this is the cannulation, and with the beating heart and the heart beating and the right lung ventilation is there, cross clamp here, and then open up the aorta and do this upper body anastomosis. So during this point, the patient is in normothermic. So once it is opened up, you could do the anastomosis to the region here. So you can anastomose at this region. So the upper body is maintained by the beating heart and the lower body is maintained by the cardiopulmonary bypass. So once it is done, what we do is, like, there is a side branch, stick in a small side branch into this one, and through this right branch, now the upper body is being perfused. Now we start cooling to a temperature around 24 to 22 degrees. Once you cool down, you have some amount of protection, and then you move the clamp sequentially downwards and complete the anastomosis. So and then, so clamp here, this is the upper body which is being perfused now, the lower body is perfused from the cannula which is below. And then you move the clamp sequentially below, one by one, and then once you reach the desired temperature of 20-22 degrees, and you open up and do all the anastomosis sequentially. This is one of the intercostal vessels which we are reimplanting. So we have different approaches. I'll show you the approaches of intercostal vessels. This is a direct approach. So the previous speaker showed where we can put a side branching, or we can do, but we have published our own technique of doing a saphenous vein graft of reimplantation. So now once the intercostal vessels are reimplanted, then we open up the lower body, all the visceral vessels lower, and then anastomose all the branches. So once it is opened up, you could see we can anastomose all the 4 vessels can be seen, and using the Coselli branch, we can anastomose all the 4 vessels here. This is the post-operative CT for this particular patient. Other is the branch first technique. This is a 24-year female guy. So here what we do is actually, we open up and all the 4 branches are looped up, and all the 3 branches, the celiac, SMA and the left renal arteries are looped, and then what we do is we sequential cannulation, femoral artery is cannulated, and then that is a routine procedure. And the side branch of the Coselli graft is also cannulated, so that each branch, so you could see here, so it is divided within 20 minutes or something like that, a ischemic period which can be tolerated in normothermia. This can be anastomosed onto a branch graft, and through one of the side branches, this particular artery is done with perfusion. So there is no division of the aorta, and the perfusion is being continued. But the downside of this particular approach is that not all the patients will be able to get this one, because when the aneurysm is huge, we won't be able to reach the right side and isolate each branch. And other important thing is that all these branches we are going to anastomose into a very flimsy artery, and these are designed for the Western world where these grafts are almost 8 mm graft. So 8 mm graft is being anastomosed to a very small artery. Often we have to slit open and then do the anastomosis. So we have to wait for the long-term patency of this particular technique, and then once, because the right renal is inaccessible. So after this, after completing all the 3 branches, then we open up the aorta in a usual way, and then reimplant the intercostal and the right renal arteries in a usual fashion. So the other is, the technique is the hypothermia, mild hypothermia and selective perfusion, where we open up, there is mild hypothermia, and then selectively perfuse the all the 3-4 branches. So the SMA and the celiac are perfused with a small cannula, and then they have been cannulated and then they go ahead. And for the renal artery, there are two options. One is continue perfusion, other is give a dose of custodial cardioplasia of 500 ml and then preserve the kidney and then do the anastomosis. So there you could see through the through each branch, we cannulate it and then open up the infrarenal aorta and then do the anastomosis here. So this is being perfused. We have to be careful about giving the custodial cardioplasia in these patients up to the renal artery because they get sucked into the blood and we have to be careful, otherwise heart may fibrillate when the temperature is very low for the custodial cardioplasia. So the special scenarios are that not often we encounter endograft, suturing the Dacron graft to endograft, and that is also we have done here. This is the technique which I was telling, which we have published in our own, published from our unit with Bashi sir. So we take a renal, we take a piece of saphenous vein graft, and with this saphenous vein graft, we reimplant, because this is very easy, because as a cardiac surgeons, we have often used the vein grafts, and it is very pliable, and the control of hemostasis is also very easy. You can see the patency of these grafts in the postoperative period, and we have published this in our own journal. And if we are taking the renal, the saphenous vein, we can just implant only the arteries, and when we do patches like this, what we happen, we miss the diseased aorta, and they can get aneurysm at a later stage, and reports are there where they have to do a redo to control these dilated aorta. So this is where to a Dacron, to the stent graft, we have to reimplant this particular, What we do is we invaginate the graft like an elephant trunk into the Dacron graft, and then do the suturing. So with this type of suturing, what happens, the hemostasis is much secure, because we have to take through the prosthetic material of the TVAR graft, aorta, and then to the Dacron graft. So 3 layers has to be taken. So the hemostasis has to be perfect, otherwise very difficult with these metal pieces inside. So once it is done, then what we can do is we can just pull out the graft. You will be able to see here. Once we pull out, so the hemostasis is much secured. So this is what we are doing. We use a 3O or 4O proline here, depending upon the situation. So once this is done, you could see with the silk thread which is there, once we pull out, we will be able to get the graft here. So this is a silk thread which we have attached, and the graft is pulled out. So the hemostasis is much better in this one. And when we clamp it, and this main graft can be anastomosed here. So other is sometimes the aneurysms extend deep into the both the iliac arteries. So with an intraperitoneal approach, this is possible. Extraperitoneal, we won't be able to reach the opposite iliac artery. It becomes very difficult. But with the intraperitoneal approach, the opposite iliac artery are accessible, and we can do the anastomosis onto the iliac arteries as well. So this is use a separate Y graft and anastomosis onto both the iliac arteries, and we will be able to get a anastomosis. We will be able to get it. So doing this for a type 2 is very dangerous, because we will be denuding lot of intercostals with the Y graft. So long extent, and the paraplegia rates are very high when we do extend from the left subclavian artery down to the bifurcation here. So post-op ventilation, we usually ventilate for 48 hours, and the most dangerous complication is the diaphragmatic rupture, and other is we have to keep the patient NPO for at least 48 hours and maintain high blood pressure, otherwise these patients will end up in paraplegia. And adequate fluid is there. Keep the patient positive for at least 2 to 3 liters, because there will be a lot of insensible loss in these patients, because the bowel, the evaporation of the bowel is a lot. So we have to adequate hydration of these patients are good. Usually these patients will have good LV patients. Bad LV patients will not tolerate these surgeries. So adequate hydration is a must in the post-operative period. So these are the few cases you've seen Bashi sir's yesterday's presentation, tuberculosis aorta arthritis, which we have published in the Journal of Thoracic Cardiac Surgery. And this is a chronic type B dissection. This is a Takay's arthritis patient which we have operated. This is another Takaya arthritis patient present with severe pain which has been operated. And this is a type A aortic dissections. And another Takaya arthritis which has extensively catheterized. This is a patient from Bombay for infective endocarditis. So I take the opportunity given to me. If there's any question, I'll take it. Thank you, sir. Thank you, sir.
Thank you, sir. Now we have covered a surgical management of thoraco-abdominal aortic aneurysm repair. Now we will move forward with endovascular repair by Dr. Rochan Pant. Dr. Rochan Pant is Director of Imaging and Radiology and Consultant Interventional Radiologist at Sir Reliance Foundation Hospital. I request Dr. Rochan Pant sir to take us through the endovascular repair. Over to you, sir.
Good morning, and I'm surrounded by people who do some of the most difficult surgeries in the world, and we have been treating some of these. Okay, this is laser. This one. Some of these thoracoabdominal aneurysms, and to begin with, I would like to thank the organizers for the privilege of addressing all of you in this very august forum. And I mean, this is the standard Crawford classification of thoracoabdominal aneurysms, but in the endovascular world, this is not that relevant. And this particular screen grab is from yesterday's talk, which was delivered, which talked about the importance of landing zones in endovascular therapy of aortic aneurysms. And it's really difficult to say anything more than this. And the major concerns when we treat some of these aneurysms is what I listed on the left side. And obviously there are many approaches, as you've heard. There is a surgical approach, there's the endovascular hybrid approach, or with total endovascular approaches, you have the options of flow diverters, which really is not available to us anymore, but custom devices which are made by the companies which make stent grafts, or off-the-shelf devices, as well as physician modification of devices is the options that are presented. So basically, when you make a customized device, you have to create branches or holes in the device to accommodate the visceral branches or the branches to the cerebrovascular system, and this can be done either by the manufacturer or by the treating physician. The issues with the custom-made device in India is, of course, the cost, and there is a delay. When you place an order for the customized device, it gets manufactured specifically for that patient, comes to us, and it takes time to do that. So in certain cases, this is not an option. And so we got into the business of modifying the grafts ourselves by creating the fenestrations, using the CT scan basically as a map in planning the entire procedure and doing the entire procedure. As an example, this is one of the easier situations where you have inadequate landing zone. It's a juxtarenal aneurysm and you have an inadequate landing zone. And what we do is we modify the device and we create this situation where the renals are supplied by stent grafts placed through holes that we create in a standard infrarenal aortic aneurysm therapy device or a EVAR device, and that's what can be done. But this is not a true thoracoabdominal. This is a case that is one of the more difficult ones which were faced towards the end of COVID times. Got this call, and this patient was admitted to the hospital with COVID but developed severe pain abdomen, then crashed his blood pressure. Fortunately, as you can see, the X-ray shows clear-cut COVID here. Somebody did a CT scan, and you can see that there is a large thoracoabdominal aneurysm here. And this is a contained rupture. As you can see, there is a hematoma there in the retroperitoneal space. So we started this case in the night actually, because by the time I got there, the device has gotten, it's already night, started somewhere around 9 p.m. or so, and basically created holes in the stent graft after looking at the CT scan and measuring all the distances and diameters. And this is how we partially open the stent graft, go through the provided fenestrations, enter the branches. This is the right renal branch. Then we had to open the contralateral limb of the AAA device, which we also used here, because the left renal wasn't accessible from above because of the tortuosity. And then we calculated that from the contralateral gate of the AAA device, placed in what are called bridging stent grafts, which are covered stents, placed through these holes to seal off the entire structure from the aneurysm. And we end with this system where all the 4 visceral branches are now supplied by these bridging stent grafts. And we also placed a AAA device to exclude the infrarenal portion of the aneurysm. This is what you end up with, an entire structure that is created inside the body by assembling different parts that you put together from different axes, brachial axes. Basically, the patient is cannulated in all 4 sides, both femorals, both brachials, sometimes even more. Sometimes a carotid or a subclavian or an axillary, these can all be used. And that's the follow-up CT. As you can see, this looks very good. And this was 22, and of course we kept the patient in the follow-up. This patient did develop a little bit of muscle weakness in the lower limbs. However, over the next 3 months, he completely recovered power, was normal. In March 2024, the CT scan reveals a large endoleak. So what has happened? Please recall this case was done on an emergency basis. What we found was that the patient had this happen. That bridging stent graft into the SMA is fractured. So is the one into the celiac, because as you all are aware, the aorta is a dynamic organ and over time it changes. It elongates, tortuosity increases, all these stresses impose loads on this structure that it's really not designed for, and these events happen. So then we had to go in again and repair all of this by placing fresh stents or stent grafts into these fractured bridging stent grafts. Through femoral axis mainly, and after this was done, as you can see now, here, if you look carefully, it's completely divided into 2 parts. This is to explain why am I presenting this case, which is not straightforward, because I wanted to make it clear that this whole system that we have of treating a complete thoracoabdominal with endovascular therapy comes with a lot of caveats. You have to follow up patients. Ideally, for patients who can withstand the surgery would be the best option. This is for patients who do not have that option or in an emergency situation where the surgery may be difficult to do. So at the end of all this, last year we managed to heal the patient again, and for some reason this video is not running. Anyway, so this was an example. Now here is a different example of a 68-year-old male who came in with pain, abdomen and vomiting, underwent a CT scan. Now this shows the aneurysm, which is thoracoabdominal. Again, this is how we make the plan. The CT scan gives us all these measurements, but it's a science, supposedly, because the CT scan is giving you very accurate measurements down to like 2-3 millimeters. But when you put in your rigid wires, your stiff wires, your devices, all these relationships do get altered. Because once you put something to straighten out the aorta, everything rotates, moves, flexes, bends, positions change, and then it becomes a little bit more of an art. So when you do this, there are problems which happen. Fairly straightforward, we went in from the brachial axis and other axes we managed to place through the fenestrations we had created. We entered each branch, both renals, SMA, celiac, put bridging stent grafts into each. This is breaking what we call the constraining suture. To keep the stent graft from fully expanding, we put a suture there with the 5-0 or 6-0 proline, and that is broken once we are across. this allows us to have a little room for maneuvering, to get some space to go through these fenestrations, enter the branches. And at the end, when we are successful, break this with a balloon. But after the procedure in the morning, it was about 6 a.m., 5 a.m., I got a call that patient is getting hypotension. So blood was started, everything looked okay, we asked for CT angiography. And by the time I reached the hospital, luckily I was right next door. This is what we find. There's a large perinephric hematoma. So what has happened here? Again, this is to emphasize that none of this is simple. Can you see that? Because of the wire that we had to place in the renal artery to get everything through, these are stiff wires and they can cause injuries to arteries and dissections. So once we saw this, simple enough, we put in a smaller stent graft and that thing is healed. And the follow-up shows a well-treated thoracoabdominal aneurysm. To emphasize, none of these is simple, easy, or without risk. It may have slightly lower risk than surgery, but it's not without risk, and you need the full armamentarium of anesthesia support, critical care, intensive care, etc. to do this. This is another example of a really long, very long thoracoabdominal aneurysm, all the way from the descending thoracic till the celiac. So we planned a 3-vessel fenestration because where there is a large aneurysm, when you put in a bridging stent graft across a long distance, that tends to fracture. As you saw in the earlier case, when you have those long bridging stent grafts, the load can cause them to break and fracture, and there is really no simple solution at this point other than to have a customized device. So we made this plan and then we proceeded. Now this is to show that we check the fenestrations. If you look here, you'll see the fenestrations. We check them under under the fluoroscopy to make sure that we can see them well when they go inside. Subsequently, in this particular case, we blocked the celiac. I think the movies are not running. Anyway. Yeah. We entered the celiac and we plugged it. After which, we proceeded in the usual fashion to put in the large device with the fenestrations. It's not running again. So moving forward, we managed to This is how we ended up with bridging stent grafts into the renals and the SMA. Finished the procedure. I really should have used my own laptop. And then we put in the next device through this to cover the part from below the left subclavian. And as you can see, it's a very long coverage. So the worry here obviously was spinal cord ischemia, and we had obviously counseled regarding this. You can see here, that's the overlapping part, and the branches are well opacified. And this is the lower end of the not running. Post-procedure, he had spinal cord ischemia, but recovered to 3/5 in 4 weeks, and at this point of time, he has no spinal cord. He has no weakness of the lower limbs anymore. To summarize, the complication rates between open surgical repair and endovascular, obviously, if you look at the immediate and intermediate range, the endovascular technique has lower complication rates. But this comes at the cost of having a higher re-intervention rate. So whenever these procedures are planned, we have to look at what is the patient that we are dealing with. If you have a 50-year-old who's otherwise healthy, a surgical option is much better. If you have a 70-year-old with IHD, which is more often the case, or with renal dysfunction, any of these, then the endovascular route is maybe a better option for that particular patient. But all endovascular therapy of aortic aneurysms comes at the cost of continued surveillance and probably re-intervention. Now this is something which is coming in now, which are off-the-shelf devices, not customized. So the idea of this is, some sizes fit most patients. So some of these are available, like this one has just become available in India. This is called the E-Inside device from Attendees. And it's a very good device, pre-wired, but comes with the caveats that many patients will not meet these criteria of angulation and diameter. It has to have a 24 millimeter diameter, and often in India that can be a problem. And the inner B study is showing good results. Similarly, there's a G-branch device from LifeTech. This is available on order, not off the shelf in India yet, but it is available if required. The T-branch device from Cook, which is the oldest of these devices, has unfortunately never been made available in India. This is what is used in UK or US for urgent cases with rupture when they are thoracoabdominal. And the Gore-Tambe device still undergoing trials, but maybe a better option. But this is the problem. These are the diameters of the devices which are available off the shelf. Please note the large sizes compared to what we see as Indian aortas. And this is Indian aortic sizes. This is, brackets is Indian, this is European and Western. You can see there is a significant size discrepancy, which is why off the shelf may not work as well in India as it does everywhere else. To summarize, customized devices can solve the problem of thoracoabdominal aneurysms. Off the shelf possibly may allow us to deal with emergencies in a very quick way, but they come at a cost. I believe the device cost about 25 lakhs, just the device. So if you put together the entire procedure, probably reach 30-35 lakhs to do it. And Indian sizes may be a problem. Thank you.
Thank you, sir. The excellent case presentation and well managed, sir. So now we move on to the next. I now request Dr. Prashant Vaidyanath, sir. He is the Director of Heart Institute, Department of City West, Kowai Medical Center and Hospital, Coimbatore, to share his experience on visceral debranching and TIVAR. Over to you, sir.
Good morning, folks. Thank you, Dr. Satyajit, for hosting a fantastic congress, and thank you for the privilege of the podium to address such an august glitterity of aortic surgeons. I have been tasked to rather form a bridge between open surgeons and the endovascular interventionalists. You see that in the endovascular option, you have a very high re-intervention rate, and also the financial logistic do not make any sense of it, because you can't do a procedure in India in 40 and 50 lakhs. It is impractical. Open surgery, like it or not, if you go to United States, as I have been going since almost 20 years, there is a degrowth of open aortic surgery, and I might say even only 60 to 70% are endovascular and hybrid. Only 30% of the aortic procedures currently in the United States is open surgery. There is a reason for that, and the reason is quite obvious. There are very few centers all over the world which can give predictable results in open surgery. The morbidity and mortality is huge, actually. Now, this is the Crawford classification we have been looking at. It is quite relevant for in a surgical context, but not in endovascular, but it is definitely relevant in a hybrid context. I don't call it types, because E. Stanley Crawford never intended to be called it types. It is called extent 1, 2, 3, 4, from here to there, extent of the aneurysm. The fifth is actually Hazim Savi's modification, who was his blue-eyed boy for many, many years. Now, open surgery, we have seen all the fantastic pictures, fantastic videos, Grotex pictures, which is quite demanding. We have seen both the techniques Dr. Hiremat presented, the branch first technique, which is actually the modification of what is known as the two graft technique introduced by Loma Linda long time ago, 25 years ago, with excellent result. We cardiac surgeon, we do not have a tendency to read Journal of Vascular Surgery. They have done hundreds and hundreds of patients with the two graft technique. Basically, you do a debranching, antegrade debranching from the descending thoracic aorta, debranch the renovisceral vessels, and then clamp the aneurysm and put an inline graft. Apart from that, open repair, one can understand after having seen all this that it is incredibly complex and challenging procedure. And despite this procedure being in vogue for 50 years, the results are only acceptable in select few centers. And that is a well-known fact. The fantastic pictures that we see suggest that the PowerPoint slides do not bleed, only the patient bleed. Complete renovascular debranching combined with EVAR offer many advantages in regards to open surgical repair with comparable or better results sometimes. Now, in a complete endovascular repair, in the previous talk, we have seen that financial implications as well as the complexity of a procedure require a definitive skill sets which is not acquired by many people. Complete endovascular repair can be an appealing method for inoperable patients, but remains from a technical standpoint probably as challenging as an open graft procedure, and there is a very high radiation exposure. Moreover, fenestrated and branch devices have to be customized, as you have heard. Although we have been doing physician modified stent graft for almost like 20 years, but it is still a challenging procedure, and of late with the available of 3-Mensio analysis, one can easily make fenestration. We can also have a 3D printout of the renovisceral segment of aorta, put a stent graft there, mark the fenestration, and do a fenestrated stent graft, which is physician modified. However, because of the hardware required in the complete endovascular solution, and also you require a multiple covered stent, which escalates the expenditure quite exponentially. So we come down to the hybrid procedure, which is the third option, first in described by Quinones and Baldrick. The principle of this procedure is quite simple to understand, that you bypass the renovisceral arteries and then introduce the stent graft. Mind well, surgeons are quite adept in introducing a stent graft very expeditiously, I would say, and it takes hardly 20 minutes to introduce a stent graft. You don't have to do anything. Any device you can use, you will have a clinical specialist, he will tell you 1, 2, 3, 4 steps, finish, stent graft is deployed. So we want that kind of scenario, but we want a bald aorta so that there are no aortic side branches. So the hybrid repairs refers to basically both open surgical and endovascular technique combined together, which is basically what I am saying. It's like an aortic team. Like we have a heart team, here you have an aortic team, you have a surgeon, and you have either a radiologist or an interventional cardiologist. So by bypassing the vital aortic side branches, it's possible to cover the origin and exclude the aneurysm completely. This visceral hybrid repairs begin with the first and open abdominal procedure to first bypass the visceral and renal vessel, followed by aortic endovascular stent grafting. These repairs are particularly attractive as they have certain distinct advantages. Number one, you avoid thoracotomy, you avoid a supraciliac aortic clamping, you avoid a left heart or a full cardiopulmonary bypass, therefore bleeding, and then you avoid a potentially the ischemia reperfusion injuries. The surgical option, what are the surgical options for a hybrid procedure? Number one is a transperitoneal approach, number two, a retroperitoneal approach, and number three, a combination of three, up to two. Transperitoneal approach is pretty straightforward. All surgeons are accustomed to enter into abdomen very rapidly. It allows the anterior access to the renovisceral vessels. There are only two small retroperitoneal incision. One is you enter into the hepatogastric ligament, divide it, and expose the celiac axis. frankly speaking, I have never exposed the celiac axis, although I don't have much experience to brag about. We have done only 30 cases of a hybrid repair. We generally bypass the common hepatic artery quite intuitively before the origin of the gastroduodenal. So celiac axis means actually the common hepatic artery rather than a celiac axis proper, because celiac axis is very small. It is very difficult to access celiac axis as such, and it is very difficult to ligate the celiac axis in order to prevent endoleak. So most often than not, the interventionalist has to coil the celiac axis after the deployment of stent graft to prevent the endoleak. The second retroperitoneal incision here is the mobilization of the duodenum. You have to divide the ligament of Treece and completely cauterize the duodenum. So by virtue of this, you can expose bilateral renal artery as well as superior mesenteric artery. The superior mesenteric artery can be challenging because the mesentery is generally onto the right side and upturned upwards. So exposure might be little bit challenging, but not as difficult for the cardiac surgeon as such. And SMA should be bypassed ideally before the origin of the middle colic artery. That is the site for bypassing SMA. The transperitoneal approach offers several advantages, well known to all surgeons: simple, fast, especially in emergency like leaking aneurysm or impending rupture of thoracoabdominal aneurysm. It allows direct visualization and evaluation of the whole abdominal content as well as infrarenal aorta and iliac vessels. Now, what kind of site inflow you want to take? There are two types. One is the retrograde and second is the antegrade. I will come to that. In the retrograde inflow, you take the opposite common iliac artery to the index site of entry of the stent graft. For example, if you want to enter through the right common femoral artery, then you take the inflow from the left common iliac artery ideally. You can go down to the external iliac artery also, but the pressure head will be low. Ideally, if your infrarenal aorta is good, then you should take an inflow from the infrarenal aorta. We don't use a branch graft, we take a aorta bifemoral graft and make into a quadruple graft. The approach has certain drawbacks. One is in a hostile abdomen when there are adhesions. The ligation of celiac trunk is practically impossible most of the time. Then fluid evaporation, body temperature, etc. There were several problems. In morbidly obese patient, respiratory failure is a known complication. The retroperitoneal approach is described as a median or a paramedian incision, although I give a modified incision from the thoracic cage downward to the paramedian region. The reason is because I have encountered a couple of cases of splenic injury in the retroperitoneal approach where I have to go back and do a splenectomy. And with a slightly extension to the thoracic cage, it is easier to mobilize the viscera retroperitoneally from the diaphragm, as well as it is easier to expose the celiac axis. So these are the examples of retroperitoneal approach. It can be time consuming actually, and the bleeding can be quite substantial because the operative time is also long, and it can be uncontrolled injury to the abdominal viscera if there is a careless retraction, because we generally use big retractors. Now, combined transperitoneal and retroperitoneal approach is also one of the modality where you can approach the renovisceral axis in order to bypass them. Now, how is the revascularization done? Basically, one is the retrograde revascularization, which is from the common iliac arteries or even from the external iliac artery. Or the second modality is antegrade revascularization, which we tend to do in a younger patients in 50s and 60s. Above 60s, we do retrograde, and below 60s, we generally prefer antegrade from either the descending thoracic aorta, proximal descending thoracic aorta, or from the ascending aorta. We have done only 5 cases of antegrade revascularization from the ascending aorta, where you put up a graft on the ascending aorta, root the graft through a rent in the diaphragm in an anti-hepatic fashion above the liver, and then bring the graft down. This is the example of antegrade debranching. Usually we, as I said, we take a aorta bifemoral graft and we suture the limbs to the aorta bifemoral graft. 12 into 6 is enough in Indian patient. Mind well, the spellings are big, renal arteries and visceral arteries and so forth, but they are just 5.5 or 6 millimeter. The average size of the renal artery is 5.5 millimeter. SMA is never more than 7.5 or 8 millimeter. The common hepatic artery is possibly 6 millimeter or 7 millimeter maximum. So you require 12 by 6 bypass aortobiofemoral graft or 14 by 7 graft maximum. We should take care that you are not compressing the ureter, especially on the right side when you are taking the inflow from the right common iliac artery. Tunneling should be meticulous. The graft should be covered always either with omentum or a bovine pericardial patch or a pericardial membrane so that there is no inadvertent aortoenteric fistulas. The routing should be smooth so that you don't have any kinks in the graft, especially in the superior mesenteric graft you have to give a lazy C or lazy X curve, because once the mesentery goes down the graft is liable to be kinked. So at the conclusion of end-to-end, this is all end-to-side reconstruction, you have to do flow interruption to avoid the type 2 endo leak so that the aneurysm sac does not feel retrogradely after deployment of the stent graft. So if the surgical interruption is deemed hazardous or risky, and it can be, then it is better to leave to the interventionalists to do a coil embolization of the particular renovascular vessels. So the next step is the endovascular exclusion of thoracoabdominal aneurysm, which can be done simultaneously. When I am fly-by-wire in other cities, I do immediately after the renovascular debranching. But when I am in my own headquarters, I usually do after 12 hours, just for the sake of convenience, and I will stabilize the normal physiology and renal function and so on and so forth. It can be done as a single procedure, it is possible to do that. And if it is done as a single procedure, obviously you are obviating the risk of aortic rupture. The access site for the stent graft is also an important thing. If the common femoral artery is less than 8 millimeter, don't try to poke it with the stent graft. They are large devices, bulky devices, and you can put a conduit on the common iliac artery, extrude it through the groin, or you can basically anastomose the conduit to the common femoral artery and just put a purse string on the 10 millimeter conduit and enter through the stent graft. Now this is an example. I am not going to show you many pictures. This is the example of a Crawford Extend 3 thoracoabdominal aneurysm. Here obviously we went for hybrid endovascular. We did a debranching. You can see the renovisceral debranching from the infrarenal aorta. All the 4 vessels are debranched, and then you deploy a stent graft, then you have a follow-up and a patent this thing. Surprisingly, the debranching procedure is a very robust procedure as opposed to a covered stenting in a fenestrated stent graft. And this surgical anastomosis, they are quite good. We also do total endovascular, but we use a 3D printout, a flexible 3D printout, where we identify the renovisceral segment of aorta, get a 3D printout, and then we mark this. The red one is the SMA, on both sides is the bilateral renal, then above is the celiac axis. So then we sterilize it, we sterilize the 3D model. Then what we do is that we introduce the stent graft inside that, and then mark the fenestration site on the stent graft. Then we resheath the stent graft, and sometimes we pre-cannulate the stent graft as well. So the newer minimally invasive treatment options have revolutionized the management of aneurysm. It also goes with the theme of Mission Hospital, which is futuristic. So they have reduced the morbidity and mortality of this complex procedure. They have also made it possible to treat aneurysm that were considered inoperable. Thank you very much.
Thank you, Dr. Prashant, sir. I think due to paucity of time, Dr. Bose has requested that we have no questions in this session. We are trying to we are eagerly listening to the keynote address by Dr. Anil Bhan, sir, our professor. And on behalf of all of us, I'd like to thank Dr. Bose for getting all of us here. And it's an amazing venture which you have done. And I think this gentleman single-handedly has improved the healthcare system in Durgapur and the surrounding area. Hats off to you, sir. Thank you very much.
Now I request the speakers and the chairpersons for a group photo, please. And Dr. Prashant Vaishnath, sir. Thank you, sir, for chairing the session. So there is no coffee break. We'll move forward with the next session. The next session is on keynote session by Dr. Anil Bhan, sir. So the chairperson for the session are Dr. V.V. Bashi, sir, Dr. Gopichand Mannam, Dr. Chandrasekhar, sir, Dr. Kunal, sir. I request all the chairpersons to kindly chair the session. So I have privileged to call upon Dr. Anil Bhan, sir, the chairman of cardiac surgery, Vedanta Hospital, Gurugram. He is the one who doesn't need any introduction. I request Dr. Bhan, sir, to take us to share his journey in aortic surgery. Over to you, sir.
इसमें पॉइंटर कहाँ पे? हाँ सर, दिस इज पॉइंटर. एक 1 सेकंड. इसमें स्लाइड शो में आ रहा है. Pointer rods, इसमें से this is forward, this is forward, this is backward, this is pointer. This is pointer. नहीं देख रहा हूँ मैं. Thank you very much, and I thank Dr. Bose and Dr. Chatterjee for inviting me to this wonderful meeting. And in fact, it's been a long time since I have not had the aortic meeting, and I think partly because Dr. Bashi did not invite me. And this journey started way back in 1994 at All India Institute of Medical Sciences, my alma mater, where I started doing the aortic work, and it's been 31 years since that, and it's been a long journey. Tough fun, some triumphs, some tribulations, but no regrets. Well, I'm acknowledging my teachers, my patients who have been responsible for creating this data, what I'm able to present today, and to my team members, the anesthetists, the perfusionists, my surgical colleagues, and most important, the All India Institute of Medical Sciences, which has given us the privilege to create this kind of work, to learn aortic surgery, and all the help we got from there to carry it on to our present day practice. Well, who can forget these two legendary aortic surgeons who have contributed so much, and we all learned from whatever they had contributed to aortic surgery. And I am extremely grateful to Professor Venugopal, my mentor, my fatherly mentor, who gave me an opportunity to do whatever I wanted to do. He never stopped me from doing anything. In fact, The promotion of aortic surgery came through him only, and he wanted the aortic surgery to be an excellent program at the All India Institute of Medical Sciences. I am extremely grateful to Dr. Nilkandan, who always told me that you have to learn aortic surgery yourself. Nobody is going to give you an opportunity. You have to experiment with it and learn. Don't be dependent on anybody. And then that's very important, because that's how I started learning my aortic work. And I'm extremely grateful to my parents, who have, with their blessings, been able to do whatever I'm able to achieve today. Incidentally, my father was professor of surgery, and he motivated me to do most of the things that I'm able to do today. The resources came from this book, a wonderful book for any beginner who wants to do aortic surgery, and also from these various CDs from Aortic Surgery Symposium, which contributed a lot to the skills of cardiac surgery, the aortic surgery in particular for me. Well, presently I am working at Medanta, from where I have generated most of this work. Bulk of this work which I am presenting today is done at that place, and I have been there for the last 16 years now. And this is my overall experience. 2,912 aortic cases, of which there are 554 aortic dissections, both type A and type B. These are all surgical cases, and 1,306 ascending aorta procedures, bentals or non-bentals, 336 aortic arch procedures, 174 thoracoabdominal aneurysms, 279 abdominal aortic aneurysms, redo aortic surgeries, which is the number is growing very fast now, is 230, and of late we started doing the frozen elephant trunk, and we have done 33 such procedures. Well, we know the natural history of these aneurysms is very sad. Most of these patients, they have a rapid growth of these aneurysms and succumb to this because of rupture. The arch aneurysms are the fastest to grow, and the abdominal aortic aneurysms slightly slower, but ultimately from the time of onset of symptoms to the rupture, it's around average of 2 years. And once there's a rupture, the mortality is very high. Indications of surgery are very standard. They're looking at the dimensions of the aorta, rate of growth, age, comorbidities, and also multiple other risk factors which make one prone to dissections and rupture of the aortas. Well, this is a ruptured aorta replaced by aorta bypass, and similarly, one more patient with a contained leak from the abdominal aorta and a huge aneurysm, as you can see here. There's been a major technological advance in the techniques and the availability of the raw material and the armamentarium, which has made the outcomes much more predictable. Namely, the better grafts which are available today to us, the better cardiopulmonary bypass techniques, myocardial preservation techniques, spinal cord and brain protection techniques. So they have contributed to a great extent to the better outcomes of aortic surgery today. I'll go segment by segment, see how we evolved our techniques in these areas. Ascending aorta, by and large, is the one which is the beginning part of your aortic experience. And today the indications are very subtle. Any ascending aorta which is made more than 5 to 5.5 centimeters is an indication for intervention. And for patients who have Marfan's or any other collagen disease are intervened at a much smaller size. Any patient with aortic regurgitation and aortic aneurysm, and patients with acute or chronic dissections are candidates for surgical intervention. Well, this is the various modalities of treatment that we have available, the most common being the composite valve grafts, and then we have the homografts, the full technique, homograft, the porcine stentless valves, which we use very frequently. We have used around 140 porcine roots. The ascending aortic graft with valve repair, the Veach procedure, that's aortic valve replacement, ascending aorta replacement, and the pulmonary autograft, the Ross procedure. Well, starting with some of the pictures, this is a patient who presented to us with a huge ascending aortic aneurysm, and it's not surprise, even today, we get patients with massive aneurysms of this size in our clinical practice, because there is generally not a very good screening program, and that's how we have delayed presentations of these patients. The rupture is not an uncommon thing to see in our practice, and this is a patient who had aortic dissection, and if you look at it, a complete circumferential tear in the intima and the media. Similarly, one more patient with a dissection with rupture, and you can see here, you can see the tear in the adventitia, and this picture is taken by a mobile picture because the patient was operated in the night. And the good outcome if you do the timely intervention in these patients. We still see type A dissections presenting chronically, and this is a type A chronic dissection. As you can see here, this is an opened up aorta, and this is after you prepare the root, the two coronaries prepared, and there is some extension of dissection in the left coronary artery, and this is an open end anastomosis, and this is the time when we are using retrograde cerebral perfusion for the brain protection. You can see the blood flowing through the SVC cannula to perfuse the brain during the circ arrest time. This is the time when we are doing complete distal anastomosis and a deep hypothermic circulatory arrest, which is no more practice. And the nice outcome of this operation. Coronary artery involvement is not uncommon in type A dissections. As you can see here, this is a completely damaged right coronary artery, and in this setting it's better to put a graft than to try to repair these coronary arteries locally. And however, in certain situations you can still save the coronary artery. As you can see, the dissection extending into the left coronary artery here, and you can do a local repair without having to put the bypass grafts. Similarly, the right coronary artery dissection and repaired locally and then implanted onto the graft. Well, this is a patient who had a complete avulsion of the right coronary artery from the main stem. And sometimes we see the coronary arteries coming off quite high up, and has to be very careful in placing them onto the graft because there could otherwise be sometimes a malperfusion of these arteries. And this is the picture of this patient, a post-Bental procedure. Last 20 years I have been doing making the tissue valve conduits on the table, and with no regrets, very good outcomes. Of course, recently now the Edward Life Sciences people have come up with the Connect graft, which is available in our country, though very expensive. And one word of caution here, this is a patient with aorta arteritis. When you are harvesting the coronary buttons, it might be very difficult because the whole thing is adherent to the tissues around it. And this is a boy who I had operated at 2 years of his age. I had done a Bental procedure for multiple root abscesses post his aortic valve dilatation procedure. And this boy is now 24 years of age. He came back for a resurgery recently for his mitral valve because he had developed mitral regurgitation. I had put a 17 size valve with an 18 size tube, which I had made on the table because 70 size valve conduit is not available. Another entity other than dissection is a type A intramural hematoma, which again we see, and the behavior of these type A intramural hematomas is just like type A dissections, so therefore they have to be treated as aggressively as a type A dissection. Earlier on, we used to follow up these patients with angiograms or digital subtraction angiographies, and this is a post-op ideal outcome, but sometimes there could be patients with pseudoaneurysm because of leak of one of the implantation sites, and this is one such picture. But however, now we follow them up with CT angios, and it's very, very convenient and very useful information which we obtain from these. This is a patient who I had done a ascending aorta replacement, had also a type B dissection being followed in the follow-up. This is a patient with Marfan's who had extensive aneurysm, and you can see we had done the ascending aorta arch, then an elephant trunk, and extend the graft down to here, and the extension of the elephant trunk graft right up to the celiac artery. These patients are to be followed up very closely, particularly the patient with Marfan's, because the rest of the aorta is also susceptible to developing disease process. Another option for patients who have got root aneurysms, with not much aortic valve involvement or not a grossly dilated aortic annulus is a valve conservation or malpreservation technique, the David procedure, which we do for only selected patients who are suitable for it, because we don't want too many re-interventions, because our patients don't want a second surgery. But this is the end result of a David procedure, very good outcome. Ross procedure is another option for this particular child who was 13 years of age with familial hyperlipidemia and had developed severe aortic stenosis. I had done a Ross procedure, and she had also multiple coronary artery blockages. She was just 13 years of age. She had a Ross procedure with multiple CABGs using venous grafts and a BioCor valve conduit for reconstruction of the right ventricular outflow tract. And last but not the least, more so in patients who have endocarditis of the aortic valve with multiple root abscesses, we found this valve substitute to be a very, very useful modality. Now, our number is around 130 patients of infective endocarditis of the aortic valve. We have used a stentless valve and with very good outcomes, with very little recurrence of infection if this conduit is used. Ideally, of course, if homografts are available, it's as good as stentless valve, but since homografts are not available, so we use a stentless valve as and when indicated. Well, interesting things are we still see this pathology like this, eroding aneurysms. In fact, I have a patient posted for tomorrow, post-CABG, who has developed ascending aorta eroding aneurysm, possibly because of mediastinitis and rupture of the aorta. Well, this is the picture, as you can see here, very scary, and we have evolved a very simple technique for these patients. This is a CT image of the same patient. We generally do a peripheral cannulation, cool them down to 18 degrees, then only open the sternum. And once we open the sternum, we'll get to the neck of that leak here and just cover it up with the patch. And the important challenge here is to properly de-air, because there is a risk of air embolism in these patients because your aorta is virtually empty. And this is the patch closure, and as you can see here, we flow slowly so that the blood keeps filling up the ascending aorta and the arch so that there is no risk of air embolism. Well, this is another patient who was referred to me for a redo mitral valve replacement, and when I examined the patient, I found a pulse-style mass, and this was nothing but a pseudoaneurysm from the aortic cannulation side, which we had to repair. And as you can see here, there is a large rent in the ascending aorta, and this had to be done first and followed by the mitral valve replacement. Extensive aneurysms still encountered in our clinical practice. Of course, the line of treatment has slightly changed. Earlier on, we used to do everything surgically in 2 stages, do the ascending aorta, arch and the elephant trunk, and then extend the elephant trunk. But of course, with the advent of frozen elephant trunk, this has become much simpler. Well, this is the patient who had an aneurysm starting from the aortic root and going up right down to mid-descending thoracic aorta. And these are the operative pictures where the first aortic root is of course saved. We did the excision of the ascending aorta and put a graft there, and this is the excised arch of aorta and the transected isthmus, and taken a prefabricated arch graft, invaginated it to create an elephant trunk, and finish the isthmic anastomosis, pull back the graft, do the arch vessel implantation, and suture the same graft to the ascending aorta graft. And 2 weeks later, go back and extend the elephant trunk with another graft to the native aorta. This is a completed procedure, as you can see here, and this is the post-op CT angio showing the completely replaced ascending arch and descending thoracic aorta. Incomplete operations are a challenge because quite often what we do, suppose there is a patient who has got an aortic valve disease and he has got a root aneurysm or ascending aorta aneurysm, we just do the aortic valve replacement and do some kind of a replacement of the ascending aorta, but we leave behind a diseased root, and these patients keep coming back for resurgeries, which is quite often challenging. I'll show you 1 or 2 patients here in this group also. Well, this is a patient who had aortic valve procedure done along with ascending aorta replacement, and this whole thing has now become a huge aneurysm, the root, and we had to go back and replace that entire aorta with the valve. And there was also a thrombus in that aneurysm, as you can see here, and this is the completed procedure. Well, 2 years later, he came back with severe mitral regurgitation because he was Marfan's patient, and I had to go back and change his mitral valve because valve was not repairable. Aortic arch, any aortic arch more than 5.5 to 6 centimeters in diameter is an indication for intervention. All otherwise patient has symptoms because of the largeness of the aortic arch and a documented progress, and unfortunately the arch aneurysms progress the fastest. And in an aortic dissection situation, if there is a separate tear in the arch or there is a rupture of the aortic arch, that's an indication for intervention. Well, the goals of the aortic arch surgery are the organ protection, a pathology-related excision of the aorta, and hemostasis. Neuroprotection is the most important thing. As I said earlier, we used to do deep hypothermic circulatory arrest along with retrograde cerebral perfusion as the preferred modality of brain protection. But now we are doing mostly selective antegrade cerebral perfusion, unilateral or bilateral. We still follow unilateral, but some of the groups do bilateral perfusion of the cerebral vessels. And for neuromonitoring, NIRS has helped us quite a bit. We do a NIRS monitoring in all these patients intraoperatively, and this has given us a good idea about the perfusion of the brain. Of course, this depicts only the frontal lobe oxygenation, but that gives a fairly good indication that the brain is well perfused. Earlier on, when we used to do cerebral protection with retrograde cerebral perfusion, we had modified the circuit, but now, of course, we are using only antegrade cerebral perfusion through the axillary route, cannulating the axillary artery, and well, this some of the cases. This is a patient who had ascending aorta arch aneurysm, and this is the final procedure. And in these patients, we have only followed the antegrade cerebral perfusion for brain protection. This is a patient with type A dissection who had also a ruptured arch, had to have a Bengal procedure with a total arch replacement. Well, some patients, the reimplantation of the arch vessels is done as a single patch, and this is one such example where we have used the single patch for implantation onto the head vessels, onto the arch graft. Distal arch aneurysm is a specific entity. Again, we used to see quite a bit of this in the past, but off late, because these patients are being managed with endovascular treatment, so we're not seeing them very often. And this is a patient who was a doctor by profession, who had a massive distal arch aneurysm just near the subclavian artery and beyond. And this is the CT scan of the same patient. And as you can see here, this is the intraoperative picture. We used to cannulate them, femoral artery and femoral vein, cool them down again to 18 degrees, deep hypothermic circulatory arrest. After opening up the aneurysm, there is a huge amount of clot in that aneurysm, and this is the extracted clot, and then suture a graft onto the neck of the aneurysm, and this is the graft, the proximal end is done. Now, important thing is how to dear the heart. For this, again, we used to use retrograde cerebral perfusion. We used to fill up the arch and the graft with that, as you can see here, slowly filling it up so that there is no air trapped within the graft and the arch, and then complete the anastomosis distally, and this is the final picture. The other thing which we still see is small circular aneurysms in the arch of aorta, which could be either secondary to tuberculosis, which we had reported earlier also, about 10 or 11 cases, and it could be even as a part of the PDA, which had closed on the pulmonary artery end, but did not close the aortic end, gradually became an aneurysm, or sometimes post-traumatic. Well, this is the intraop picture for this kind of aneurysm. The aneurysm was completely excised and replaced with the graft, and this is a post-op CT angio of the same patient. Well, sometimes if there are TB aneurysms, the problem with these tissues is they are very fragile, and putting a graft onto them sometimes can be very tricky. As you can see here, the tissues are not very healthy. There is a chance that it might recur or it might even leak, and this is the patch which has been put onto that. But of course, this is to be combined with the anti-TB therapy, because doing just surgery is not enough. One has to combine the anti-tubercular therapy with surgery to ensure a long-term benefit. Penetrating ulcers can be seen in any part of the aorta, and here in this patient, this is a penetrating ulcer in the descending thoracic aorta. This is a patient, elderly lady, she was 75 years of age, had a penetrating ulcer in the distal ascending aorta close to the innominate artery, and which we operated surgically. And you can see here, these are the intra-op pictures, and this is the defect which has been created by after excising that penetrating ulcer and repairing with a patch. Well, there was a patient who came to us with pericardial collection. It was all blood. We got a CT done. It did not show any evidence of any dissection or any leak, but the cardiologist insisted we should open it up, and we opened up. This is what we found. There was a hematoma in the ascending aorta, and when we opened up, there was a penetrating ulcer somewhere here, and it had leaked from there, and it was a sensible decision to go and repair it and change the ascending aorta rather than leaving it behind. Well, there can be penetrating ulcers in the descending thoracic aorta as well, as you can see here. And these ones are best treated with endovascular devices and not by surgery. The thoracoabdominal aorta, we heard in the recent presentation, some important information was given to us, and we know there are multiple issues with the thoracoabdominal aortic aneurysm repair and the adjuncts to the surgical repair, which also has been talked about in detail, and spinal cord protection being the most important thing, and I think we did a detailed discussion on that. And this is the setup that we make. We usually perfuse the vessels through the BCD system, and this is a nice setup, and we use 6 French Fogarty, 6 French retrograde cardioplegia system for that. You can see here this cardioplegia system, the left renal button, and these we perfuse all the visceral vessels at the time of surgery. When we were repairing the thoracoabdominal aneurysm repairs earlier, excuse me, and the Kasoli graft was not available, I used to make these grafts myself. As you can see here, I used to go and spend some time with the radiologist, see the relationship of visceral vessels and also the distances between these vessels, orientation, and then make the grafts myself. But of course now the Kasoli graft is available, it's become much easier. And you can see here, this is the one which I have, these grafts I have made myself, and these are the visceral vessels which I used to put on it and anastomose to them with respect to visceral vessels. This is a completed procedure, and these are all the vessels, as you can see, the implanted vessels from the back. And this is the post-op image of one such patient where the visceral vessels have been implanted onto the graft. This is another patient who had a root aneurysm and had no aortic regurgitation. She had a mitral valve regurgitation. LV was dilated, as you can see here, and she also had a thoracoabdominal aortic aneurysm. I did a David procedure and a mitral valve repair in the first sitting, and everything was well. And then we went back and did this part of the aneurysm, where we replaced the entire descending thoracic aorta and the upper abdominal aorta, as you can see here. These are the intra-op pictures. And what I did here, the SMA and celiac were very close to each other, and below that the aorta was normal. So I put a 10 millimeter graft to the ostium of the SMA and the celiac, as you can see here, forming a loop, and anastomose that side to side with the main graft. And as you can see, these are the post-op images. You can see the graft functioning well. And the interesting thing is, this operation I did in 2011. And she came back with severe mitral regurgitation now, and I had to replace her mitral valve. And when we did a CT angio, the C loop is still functioning very well. It's after almost 15 years. Another patient who I had done a type A dissection and came back with abdominal pain. He went to some general surgeon who treated him for some acute abdominal condition. Then he was not doing well. So he came back to us, and when we found this huge aneurysm, we had to operate on him. There was a dissection there, and this is after the surgery is over. You can see a linear tear in the back wall of the aorta, which was giving him severe back pain because it was almost eroding into the vertebral column. Well, as I said, now the Kasoli graft is available to us, so we feel much more comfortable doing with this prefabricated graft. And this is the retractor which I have designed and developed for the thoracoabdominal aortic aneurysm repairs, and very useful and very simple. The frozen elephant trunk is something new which we have started doing, and we have done 33 patients now. Well, these are for patients who are otherwise very challenging. When this patient we had done a Bental and he came back with this about 7 or 8 years later, and we went back and did an elephant trunk procedure, and as we know this is the device and this is the final CT after the procedure was done. Very useful, and I think much more simpler than doing a 2-stage elephant trunk procedure, which used to be a little more complicated. And this is one patient where I have done a complete aortic replacement. This is, I did his surgery when I was at the All New Institute of Medical Sciences. He had complete aorta arteritis, as you can see here, and the whole of the aorta right down was involved, and there was a large iliac artery aneurysm also. We did the same way in 2 stages. We did the first stage ascending aorta and arch and the elephant trunk, and the second stage we extend the elephant trunk down, and you can see his multiple incisions on his body all over the place. And this is the post follow-up CT, which was very good, but later on, about 7 or 8 years later, he developed a small aneurysm in the vicinity of the renal artery. He was not willing to get anything done. He is under follow-up, but I think he is doing otherwise okay. The iatrogenic dissections are another problem. This is a patient I did an aortic valve replacement, and in the post-op period in the ICU we found her right radial pulse had disappeared. So when we got a CT done, it showed a dissection in the arch of aorta. So we went back and we did an aortobicarotid bypass on this lady, and she developed infarct in the brain with multiple hemorrhages. So we had to do a decompression craniotomy for her, but she recovered. It took a long time. She took almost 2 months to recover, and subsequently was discharged in a much better condition. Well, another problem which we see now is the post-CABG aortic dissections, because most of the CABGs are now done off pump, and you are clamping the aorta at a maybe higher pressure, and with all the underlying dilated aorta or thinned out aorta, the chance of developing dissection are high. Well, this I have done I think 14 or 15 of these post-CABG dissections now. This is a patient whose all the grafts are patent, and she developed this unfortunate problem, and this CT scan done prior, and this is the X-ray. See the hugeness of the ascending aorta and the dissection flap within, and the patent internal mammary artery. And this was the intra picture. I harvested her the patent graft, and mammary was already functional, and did the ascending aorta replacement and reimplanted the patent graft onto there. And this is the post-op CT of the same patient. Redo surgeries are now becoming a big issue because, as I said, the first surgery may not have been done complete, so we are getting a lot of redo aortic surgeries, maybe 3 to 4 every month. So we are ready for this challenge, and as you can see in this particular patient, he had a Bental procedure done. I think it was done the wrap technique. It was not done by me, it was done by somebody else, and he came back with a huge pseudoaneurysm, and when we opened up, we found that the right coronary had got detached from the main graft, as you can see here, and the blood was flowing freely, and there was also a rent in the native aorta to the prosthetic aorta area, and we repaired that and got down the right coronary artery, which is here, and anastomosed it here. And this is the intra picture of right coronary artery being sutured to the ascending aorta graft, and this is a post-op image of the same. And post-AVR dissections is yet another entity which we are seeing more often now, because when we just do aortic valve replacement on a dilated aorta or a thinned out aorta, they have to come back with this particular problem, and a very serious problem, a very difficult situation. And you can see here the whole intima is detached, and this is after we disconnected everything and got ready the root, and subsequently surgery was done the usual way. And this is post CABG ascending aorta aneurysm. As I said, we are now having a lot of redos to do, and be mentally prepared for it. Well, there are certain post-operative concerns following the thoracic aortic aneurysm repair. One is the neurological issues, more so in patients who have an arch repair, spinal cord injuries in thoracoabdominal aneurysm patients, post-op renal dysfunction related to prolonged cross-clamp times, and bleeding. We are part of the IRAD, which is, our center is the only center which is part of the IRAD in this country, and third center in the Asian continent, and ongoing lot of research is happening in our unit vis-a-vis the aortic diseases. There's been a tremendous progress made in the diagnosis and management of aortic aneurysms. Improved results have been achieved in all segments of the aorta. The future research should focus on development of more sensitive, non-invasive techniques for serial evaluation of asymptomatic aneurysms and develop techniques for refinements of organ protection, particularly the brain and the spinal cord. Thank you very much, and I would be grateful to the organizers for letting me come here and making my presentation. Dr. Bose wanted me to make a brief video presentation on TAVI valve explantation. Okay? इसको वापस ले जाएंगे वहाँ पे जहाँ पे था ये. उसी में था इस फोल्डर नीचे. So as we are getting ready to face more of these problems, TAVI becoming such a common procedure being done in younger patients and going beyond the indications of the TAVI procedure as of today. So I think all of us have to be mentally prepared to deal with this problem, and it's not an easy problem, let me tell you. Explanting these valves is a tedious job, because more so if the procedure has been done more than a year back, the explantation becomes more and more difficult. Well, this is one of the TAVI valves done 2 years prior to our intervention. And the most important thing is that you have to find the plane between the native valve and the TAVI valve, and be very careful about 3 structures in the left ventricular outflow tract: the mitral valve, the perimembranous area, and also the coronary arteries, which are very, very close to it. In this particular patient, I'll show you, they had done a TAVI along with a stent into the left main, because I think that was a bailout procedure that they had done, because there was some problem at the time of TAVI implantation that they had to they were forced to put a stent into the left main. In an article published in April of last year in Annals of Thoracic Surgery, they showed that TAVI explantation has become one of the fastest growing operation in US. So all of us have to be ready with this, and I always say that if you are going to do this procedure, you should be mentally prepared how to deal with the aortic root. 15% mortality and 5% stroke rate. Yeah, and 50% or 15% operative mortality and 5 to 6% stroke rate. I think one should start doing from the right coronary sinus area because that is relatively safe. If you start from the back side, you probably hit the mitral valve and stay away from the commissure between the non-coronary and the right so that we avoid the conduction tissue. You can see the stent in the left main. I still remember I had to make my first presentation about... No, you start off from the right coronary sinus area because that's relatively safe area. Then you start extending. You have the dissector and use the dissector to slowly separate it from the native valve. And once you get that plane right, I think then it becomes a little easier to do it. But I don't think we should start anywhere close to the left coronary sinus or the junction between the non-coronary and the right because there you're going to hit the conduction tissue. As such also, once you explant, the incidence of heart blocks is much higher. I think it took me around 15-20 minutes to take out the valve. And then I took out the stent as well because I was not comfortable leaving the stent behind. And I was mentally prepared to do bypass grafts also, but after we took out the stent, we realized the left coronary was okay, and I documented by the post-op CT scan as well that the left coronary artery was okay. He sent me a message just 5 days back that I'm going on a tour to New Zealand. Really tricky matter to pull out the stent. In fact, in one of the sessions where I showed this video, Vinayak Bapat was also there. So he said it's very scary. I said I was mentally prepared to do the bypass grafts. It wasn't like that. But since we got it out and we ensured that the left stem was okay. No. I think at the time of deploying the valve, they must have had some doubt that they have probably encroached on the left main stem, so that's why they put a stent there. That's the left main, you can see it. It's basically it was a normal left main. Yeah, it was a normal left main. It was, I'll show you the... This is the post-op image of the left main, and there was additional stent even beyond this and the valve that we have put in. Thank you very much once again, Dr. Bashri, Dr. Sarkar, and I think I would say that the current generation has to pick up more of aortic work. There is not much interest, unfortunately, but I think the younger generation has to start doing more aortic work because that's the future. Coronary work is going to go out of our hands. So is the valve. But aorta is still, I think, with us. Thank you very much. Charges भी मेरा है. Yeah, sure.
I call upon Dr. Jacob James Raj, Dr. V. Devaguru sir and Dr. Satyajit Bose sir to join the stage for a group photograph. Thank you, sir. So now we move forward with the next session, that is advances in aortic surgery. The chairperson of the session are Dr. Chandrasekhar Padmanabhan sir, Dr. Pradeep Narayan, Dr. Debashish Das. I request the chairperson to kindly chair the session. Dr. Chandrasekhar Padmanabhan sir. So for next, I request Dr. Gopishan Mannam sir, Managing Director and Chief Cardiac Surgeon, Star Hospital, Hyderabad, to give tips and tricks in MICS Bengal procedure.
Thank you very much. I want to congratulate Satyajit for creating such a wonderful platform for the aortic surgery, and it's a great knowledge that's being disseminated yesterday and today. Thank you for making us part of this program. Yeah, that one, yeah. So now you've seen most of these complex aortic work in an open sternotomy or multiple incision settings. This is forward, thank you. So what my subject is to see how we can do these operations safely through a much smaller incision so that the patient's outcomes are even better. Their experience through the hospital and subsequently are going to get better while you're accomplishing same surgery, which will benefit them in terms of their disease alleviation. So to that extent, we start with the most easiest part, that is the root, ascending aorta, and part of the arch. Now the minimally invasive access has become very popular, and probably in some centers it has become the standard of practice. Safety is obviously the paramount, and that's already given. So now we look at the ascending aorta, and various parts of the aorta can be affected in a given patient or multiple patients. So the ascending aorta can be just sinuses and the root along with the valve disease, or it can be part of the ascending aorta, or it could even be as high as proximal arch in terms of zone 1 and 2. So what we've created an experience of access based on the pathology that we encounter, whether it is root or and further up. So what we now realize is using the accesses based on the aortic involvement is fundamental. So this patient, this is a paper published by an Australian surgeon recommending only upper median sternotomy, that is minibrim sterni incision, where you have access to the entire aorta and also head and neck vessels and part of the arch. So we use this technique to help this young man who is 40 odd years with ascending aorta and part of the arch getting involved in this innominate artery. But then as you go down on the zones, this becomes normal. So what we decided is we use the median sternotomy, upper median sternotomy, and oops, sorry. How do I go back? Yeah. Oops, shit. Can you play? Yeah. Yeah. So this probably most senior surgeons are familiar with this kind of access. This is the head, and that's the feet of the patient. You can go into the jugular notch a little bit further if you want to access the head and neck vessels, and the arch is very much accessible there. Can I fast forward this a little bit? That's fine. Yeah, okay. Just leave it. It's okay, don't worry. So, this is a standard approach. Once you open up, we would tend to take out a lot of thymic fat so that you have a better access, better visibility, and that's the innominate artery being taped. We also tape the left carotid, and that will give me an access to clamping between the left carotid, between the innominate and left carotid, and then go through the standard surgery. This is a patient who has aortic regurgitation. We tend to put a lot of tapes around, and yesterday there's a video you saw a clean dissection between the ascending aorta and the pulmonary artery, and that is the key. You need to divide. You need to create a space between the two great vessels, and this is once you collapse the aorta, you have a lot of space to work with. And you can see a very thin ascending aorta there, and that's the left coronary being quadriplegia, and this is the right coronary. And he's a young man, so we decided to give him a mechanical conduit, mechanical valve conduit. And here we do a lot of dissection to make sure that the pulmonary artery is separated. Right RPA is also completely dissected out. And from external side, you can actually dissect a lot of left main going under the main pulmonary artery. And once you take out the dilated and diseased part of the aorta, you still have a lot more space to work with. The mindset for any beginner is how am I going to access, is this going to be visible, is it safe and all. If you see that, this is no different between an open operation and in terms of visibility, in terms of access and all. This is the left main coronary left ostium being dissected out. This part is a little bit vascular, so we tend to use diathermy to make sure that we don't leave any raw area. And of course, this is a standard way of replacing the aortic valve, decalcifying and all. As you can see, it's very important to make sure that all the crap of calcium is taken out so that you don't end up with CVA later on. Meticulous decalcification always helps with not only placing the valve better, and so post-op paravalvular leaks are much less. So sharp and blunt dissections. I'm sorry, I can't fast forward this. What is this? No. So there's nothing different in terms of standard aortic valve replacement. You should be able to place sutures in whichever way you want. The other thing is that I tend to overlap these sutures coming through the annulus of the or the sewing ring basically. so that there is no gaps that are left which subsequently have a chance for them to leak. So this is one way of doing it, and there are other people who you leave a rim of aorta at the bottom and then they sew onto the graft, whichever way is comfortable. There's a lot of mindset that is necessary to be won over to make minimally invasive as one of your way of doing things. I tend to use, I don't use left atrial drain, the vent. I use plastic pediatric vents so that it can go directly into the left ventricle. And as someone showed yesterday, I think Kanwe Mule or Hamdale showed, it's nice to go very close to the ostium. It is daunting to begin with, but it's nice to go very close to the ostium when you're taking sutures, and also use the adventitia, all around the ostium as your buttress, so that it gives you a very good hemostatic sutures all around. Spending a little bit time on this, I have two more videos, but I'll hopefully fast forward them. Again, you can see very thick adventitia, which you normally dissect out from the RPA, so that will help you as a hemostatic buttress. And this is the right coronary dissected out. Sometimes you can leave a little bit of the aorta at the bottom, so it becomes a double layer. Because you don't have much of adventitia here, RVOT is right there, so you need to be careful not to tear that part. We tend to use 5, just like everybody else, 5-0 proline for the suturing of the graft. And we left a little bit of aortic rim there to give that additional strength to the already dilated and thin aorta. I leave some of these tied down sutures so that it allows me to pull the entire field towards you. Because it's a minimally invasive surgery, it's nice to have those tractions, not too hard, so that later on it kind of bleeds. So this is a hemi-arch. So now we're giving cardioplegia there. So this clamp is reapplied between the innominate artery and the left carotid in an oblique way, so that you have a beveled cut into the lesser curvature of the arch, and then the original clamp is taken out. And the innominate, what we do is we put a cannula, pediatric aortic cannula, directly into the innominate to give innominate antegrade perfusion. Left carotid is being perfused anyway, so now I have an opportunity to cut this in an angulated fashion, so it goes underneath the arch. So hemi-arch can be done through this kind of approach, still minimally invasive. I don't really use this as a routine Bentals if it doesn't involve the distal ascending aorta or the arch. For simply, this is slightly more less appealing to cosmetic point of view, And also there are easier ways to do it, Bentals through the right anterior thoracotomy or transaxillary approach. So I'll stop here. This is now, we're going to take out the innominate artery cannulation just, so it becomes very easy. So hopefully, so this is the transaxillary approach. This is the incision, and that's how usually we choose third intercostal space, and it's about 4 to 5 centimeters incision. Make sure once you have gone up to the bone, you make sure that before entering into the intercostal space, you count the spaces again. You don't want to be too high, and you certainly don't want to be too low. So about third space would be nice, or you can use CT scan as your guidance. This patient had a 5.6 centimeters ascending aorta with severe aortic stenosis and LV dysfunction. What is important is studying the imaging, sitting with the radiologists, asking them to show and rotate it around. You should get a great mental visualization of how the aorta would be, and you can always use these pericardial traction sutures differentially to bring the aorta into your wound. So you can see very clearly now, and you can access any part of the aorta up to the pericardial reflection through this incision. That's the RPA down there, and you make sure that you dissect out all the pericardium, all the epicardium, so that will be useful for you later on. So I'll move on to the next. This is just want to show you the traction sutures, how they will help. This is a very deep suture onto the left side once you cut the pericardium, and if you clearly see the aorta is far to the left, but once you do the traction, it comes right into your wound. So this is standard right thoracotomy. This is a 61-year-old lady, which recently we have done at 1.6 BSA, but has a 35% ejection fraction with ascending aorta 4.2. On CT scan it's 4.3. So if our primary operation is for the valve, and if the aorta is beyond 4 centimeters, we tend to also do Bentall's procedure because the risks are about the same. This is the ascending aorta, but upper part is relatively okay. So again, this is right anterior thoracotomy. You can easily access again. We tend to, placing the cross clamp, you ask the perfusionist to go to zero flow, get all the blood drained so that the aorta becomes very supple and easy. Pull it down towards the feet, and when you're applying the clamp, so it go all the way to the pericardial reflection, and now you have the cardioplegia can be given, and make sure that you dissect out the aorta further. It take 1 minute, 1 2 minutes, yeah. And that's the pediatric vent that I use for this. Look at the aorta is very, very thin. This is very important. As you go down with your aortic transection, make sure that you leave a little bit of sleeve more than what you think is necessary, because sometimes it slips back, and this is the dissection between the pulmonary artery and the aorta. That part becomes very important post-op also, in case if you have a bleeding, to have a free space all around will allow you to identify the bleeder. In this particular approach, the right coronary becomes a little bit difficult because the space between the the back of the sternum, and the aorta becomes relatively less. Doing a left coronary arterial reimplantation is not a big deal. I always make sure that the RPA, the adventitia on the RPA is dissected, especially towards the left main artery, and go underneath the main pulmonary artery, so you have enough length of the left main mobilized. And I generally use diathermy. People can use sharp dissection with scissors, whichever way you want, but make sure that you have this left main and ostia are freely mobile. And then this part, again, use diathermy to make sure that the fat is not raw. Again, make sure that no calcification is left. And then this standard suturing. This lady is 65, I think. So we used a Biovental prepared on the table with a 21 Inspiris valve put into a 24 conduit. We call this as spike sutures. It's not backhand, it's not forehand, it's kind of looking at you as a needle looks at you. So it becomes easy to pass through, especially the right coronary sinus area. And crossing on the other side, also make sure that there is no space between the two sutures. So I always go on the inside of the previous suture so that there is absolutely no gap between these sutures for them to leak later on. Yeah, thank you.
Thank you, Gopi.
Just want to show one slide. This is a slide from Bristol which has shown very clearly, if you look at on that side, that's the median sternotomy. On this side, this is the minimally invasive surgery, and most of the complications seem to be on the median sternotomy side. And these guys actually did a meta-analysis of this. These are the number of patients that were in this study. So, although the evidence is not great, the minimally invasive surgery aorta appears to be safe, but the quality of evidence available is low, so we need to start building that kind of evidence. Okay, thank you.
Thank you very much, Gopi. I think we'll leave the questions after the last talk, if you have time. You can come and take a seat here, and if you have any questions.
Thank you, sir. Now I request Dr. Prashant Vaijnath, sir, to take us through TAVI, the surgeon's perspective.
Good morning, folks, and thank you again. I was actually not very sure what I am supposed to present regarding the surgeon's perspective. I guess it is a hot topic. It is a hot topic, and there are a lot of been raging debates going on whether surgeons should dabble into this field or not. I will give certain philosophical aspect of it rather than scientific aspect of it. Now, my teacher, Dr. Bhan sir, from All India Institute, has said very rightly that TAVI explant is one of the growing operation in the United States. But we have to take into cognizance also that 80% of the aortic valve replacement in the United States are TAVR now. And he has quoted from the explant TAVR registry, but then you go onto the VIVET registry, which is valve-in-valve registry, where almost hundreds and hundreds and hundreds and thousands of surgical bioprostheses have been treated with valve-in-valve. So you have two sets of data, so you can judge for yourself. As for my disclosure, I am a proctor for 3 international companies for 5 countries, and I'd rather not use the word proctor, which is sort of insulting. I would say partnered with 15 cities of this country for performing TAVR specifically by surgeons.
Now, why cardiac surgeons should be trained in catheter-based interventions? Although you can see that the lines between traditional surgical procedure and minimally invasive intervention continue to blur. What we are calling as a minimally invasive cardiac surgery, I don't believe in that. Absolutely not. It is a misnomer. There is all sorts of invasiveness here. There is a cardiopulmonary bypass, there is cutting, suturing, ICU care, so on and so forth. What it is, what I like it to be called as MACS, minimally access cosmetic surgery. That is what it is. The true minimally invasive surgery, of course, minimally invasive procedure is the percutaneous procedure. And we believe that the integration of the catheter-based interventions into the skill sets of cardiac surgeon is extremely important in order to, I would say, to satisfy a simple Darwinian principle of survival of the fittest. Otherwise, we are going to be extinct. And this is not like crying wolf all the time. This is going to happen. And this is happening. And we are seeing the, you can say, repercussions of that. I would say that there are 3 generations of cardiac surgeon, if you generationally divided. One is a generation between 30 and 45. I would call them, who are sitting here in the majority, they are younger surgeons. Second is my generation from 45 to 60. And the third is Bhansas and Bashish's generation, senior surgeons. But we have to evolve and change with time. That is inevitable. Otherwise, we are going to be obsolete. Now, we all know what is the law of instrument given by the famous American philosopher Abraham Maslow, that it is tempting to treat everything if it is as if it is a nail, if only the tool you have is a hammer. And surgeons should have the ability to be actionable and adaptable, and that actionability and adaptability is going to create more opportunities. Traditionally, the cardiac surgeons, admittedly, have been stalwarts of heart care because the era of transcatheter technology in this country was heralded by us when we did the first transapical transcatheter aortic valve implantation in Chennai in 2010 and published it. Subsequently, in 2012, Dr. Ashok Seth in New Delhi did a transfemoral TAVR. So even in this country, a surgeon has to do a transcatheter valve implantation. So the advent of catheter-based interventions such as PCI, we have had a very bad lesson, bad experience of PCI. United States, you go to Mount Sinai, 25 years ago they were doing 1,000 coronary artery bypass. Today, regrettably, they are doing 150 coronary artery bypass per annum. This is a shocking data that one comes to understand when we look at it in a very rational fashion. These minimally invasive procedures offer significant advantage. There is no doubt about that. There is reduced patient recovery time, lower risk of complication, and ability to treat patients deemed too high risk for conventional surgery. I can admit myself that I have not done a redo mitral valve since last 3 years. The only redo mitral valve I have done was the thrombosed mechanical heart valves. Those are the only redo I do. Most of the patient with structural valve deterioration at mitral and aortic position, we do with transcatheter technology. Patient is discharged within 48 hours without blood, without ICU care, without anything. And they get a similar results, or sometimes superior results. Now we must take a leaf and we must have a sneak peek at how the vascular surgeons, they have applied the Darwinian principle of survival of the fittest, and how is the evolution of the vascular surgery. It provides us, a cardiac surgeon, a very valuable historical example of clinical adaptation. How the specialty was preserved by adopting a dual system residency, how was the training program designed, how were the ability and willingness to learn new skills were appreciated. When I was doing my Master of Surgery in PGI Chandigarh, my batchmate, Premchand Gupta, I went into cardiac into All India Institute. He went into vascular, he went to Japan, got trained himself. Today he is the president of the Vascular Society of India. And they do all sorts of endovascular interventions. It is remarkable to learn something from those people. Now, bridging the gap, surgeons in the cath lab, what is the rationale of training cardiac surgeon in catheter-based intervention? That is multifaceted. Firstly, it ensures the surgeon to give a drop-down menu. You can do a cosmetic surgery or minimally invasive so-called surgery. You can do an open surgery. You can do an endovascular procedure. You can do a transcatheter procedure. That's how we should be giving to the patient. And these examples are all over the world. It's not like these are rare examples. You go to France, Lille, you have surgeons heading the department. You go to Germany, they are heading the department. You go to Italy, in Ancona, where everything is done by the surgeon. They just give a drop-down menu to the patient and ask them, what do you want? We can do everything. The breadth of expertise, this allows for more holistic approach to patient care, wherein surgeon can tailor treatment plans according to the individual needs and conditions of the patients. Surgeons have to accept, in all the minimally invasive meeting, what we discuss is very funny actually. We discuss, I give incision here, I give here, I give here, I give here, etc. My personal preference in transaxillary, by the way. But that is all we discussed. In a cardiological meeting, I go to Sydney Val, London Val, China Val, Brazil Val, I am a member of all, and India Vals, of course. Cardiologists, they don't discuss all the damn shit. What they discuss is how to standardize a procedure, how to go in a protocolized fashion, how to give a uniform, better, best, excellent results. That's how they discuss. Let's say, for example, the access site. They are not going to fight over it. They'll say, yes, we have a consensus, an ultrasound guided microneedle puncture is the best thing to do. And everybody will start master that technique. That's how they function. Surgeons should be conscious that if a small incision is good, then no incision at all is best actually. When you are not doing an incision, that is a better scenario. They also should be conscious of the risk of not performing high quality surgery. Surprisingly, one of the leading interventional cardiologists in South India, he put up a cardiac center recently, 10 days ago, and he asked me, sir, please come and operate. You should be doing the first case. I did 2 cases there. I asked him, you're an interventional cardiologist. Now you should be marketing, so we should be marketing a minimally invasive surgery. So I said, should I do minimally invasive? He said, no sir, give as big incision as possible, because my whole business of interventional cardiology is dependent on your minimally invasive fashion. I do most of the intervention in most of the minimally mid caps. I was shocked to learn that. Now a surgeon should have a change of mindset. Adding more tools to the treatment box is good. There should be no debate. Why there should be debate of learning new skill sets? I am very astonished, surprised and taken aback when we surgeons discuss, why should we learn this thing? We are diluting. You are not diluting anything. I am not spending my 90% of the time in transcatheter technology. I am spending just 5% of time. But intuitively, I have seen 15 surgeons in 15 cities, they can do a transcatheter procedure far better than an interventional cardiologist. And there is hardly anything to remember. This mystifying of guide wire, catheter skills, etc. is a nonsense. Basically, surgeons are technically skilled, dexterous, and they can handle any equipment as dexterously as any interventional cardiologist. And they do you might be surprised that most of the surgeons, they do TAVI in 30 minutes, 45 minutes. And these are the younger surgeons who are completely hesitant to start it. Now, cardiac surgeons, they should offer all conventional surgery, TAVI, minimally invasive, and they should manage the complication as well. So it is imperative and it is mandatory that we should look at our business model. A portion of our business will need to be non-surgical. It is disappointing to those, including myself, I am no exception, who entered into the field for the love of operating. Or was it the love for cutting? What about the patient care? Our job, fundamental job, is to give as better option to the patient as possible. And this fabric of stark reality, we have to realize that patients are going to seek less invasive option. When we are getting old, we will also seek that. At the age of 80 or 75, we will say, okay, let me have a TAVI. We are not going to debate the statistics and the so-called results. And as the indications of the tower risk decreases, the obstacle to the entry in this arena may become insurmountable to traditionalist surgeons. Now there is always a dilemma how to enter into this field, how to be truly proficient, how to do this procedure from A to Z instead of standing outside the cath lab and observing. So there is always if Jim Tobin was asked what is the definition of economics, can you define it, can you sum up economics in a single word? He said, yes, of course. The definition of economics is incentive. This is all about incentive. This is all about economics. There is no science in that most of the time. So as in United States, the reimbursement is given when both surgeons and cardiologists they sign on a tower case. Similarly, if the reimbursement is given in India in that fashion, or you reimburse the cardiologist when you are doing a surgical aortic valve replacement, you are still in a win-win situation, because they will charge $1 lakh for tower and you will get still 50,000, and you will charge 50,000 for shower, they will get 25. Now Charanjit Chahal has written a fantastic article in circulation that how the interventional cardiology team is trained in structural heart disease. So there is a first coronary training to be familiar with the guide wires and the catheters. Then there is the structural heart training where you have imaging training, echocardiography as well as CT scan, MRI, etc. Peripheral training for large bore management, etc. Then complex coronary or percutaneous mechanical circulatory training. Now here in this model you see that you have a broad heart team approach. Many times we have lamented n number of time ad nauseum that heart team is just only in letters, it is not in spirits. Actually the heart team can be made into letters and spirit, but there is a way to do it, that the surgeon first have to be proficient in the knowledge and they should acquire cognitive skill. Now in this basically you have various building blocks where you should have an ability to do large bore sheath management, transeptal puncture. Most of us, we don't know what are the types of fossa ovalis, what are the quadrants of fossa ovalis, which quadrant is used to access which type of pathology like paravalvular leak or transcatheter mitral valve implantation, navigation within the left atrium, hemodynamics, then LV apical entry and exit, catheter skills, intraprocedural imaging, occlusion, valvuloplasty and sleeve. These are the building blocks, and then you should have a device specific training. When I go as a proctor abroad, most of the company they cannot afford to even spend for clinical specialists, so I prepare my own device and implant it. So these are the building blocks. Let's say for aortic valvuloplasty you should have catheter skill, you should have large bore management skill, you should know how to do valvuloplasty, and then you should know the hemodynamics. Similarly, the building blocks can be built. So I will not dwell into the devils of the details of what is the current status of TAVI, but I will say that there are certain unmet needs in transcatheter aortic valve implantation even at this juncture, but the field is rapidly evolving, the technology is having a lot of iterations, and it is one of the most disruptive technology introduced in cardiac sciences in last 30 years. There have been a lot of technologies introduced, Robo was introduced, TMR was introduced, but can I have a couple of seconds? Okay. So you have challenging anatomies, bicuspid, this is more or less taken care of. Annular and leaflet calcium can be a problem. Horizontal aorta, you have an entry problem. And then you can have conduction disturbances. Most of the thing, you will be surprised that most of the things are mitigated. The incidence of complete heart block with a cuspal overlap view, even for a balloon expandable valve, is less than 2% now. Less than 2%. In the last consecutive 100 TAVR which I have done personally, there was not a single complete heart block. If you do an intentional higher implantation, if you measure the length of the membranous septum, and if you see that it is never crossing 6 millimeter, you will never have a complete heart block. Then current generations of TAVI, I think there is a field which is rapidly evolving. I will not go into the details. But in conclusion, I will say that the training of the cardiac surgeon in catheter-based intervention is not just a response, knee-jerk response to technological advancement. It is a forward-looking approach to a patient-centric care. And there is no need to fight with the cardiologist. There is no need to be fighting with the cardiologist. What we should do is that we should beat our swords, or we should beat our scalpels into plowshare, or rather catheters, and our forceps into guide wires, and then only the nation shall not take sword against nation, and they shall never know the war. The Talmudic interpretation of Prophet Isaiah was that you must always have a sword in order to prevent war. Thank you very much.
Thank you very much, sir, for a very interesting and take on TAVI. Do we have time for questions? We don't have time for questions. So we'll have to...
We'll have photos with Prashant Vaishnath, so we'll have...
Sorry?
We'll have photos.
Photo. We have time for photo, we don't have time for questions. That's okay.
Thank you, sir, for joining the session. Now we move on to the second last session. So for that I call upon Dr. V. Devaguru sir, Dr. Naresh Kumar, Dr. Rakesh Naik and Dr. Ayush Goyal to chair the session. I now request Dr. V. Pasha sir to share his experience on PET, personal filter.
Once again, I take the opportunity to thank Dr. Satyajit and his team for arranging such a wonderful meeting. I think we had an overdose of time towards the back end of the day. I won't take too much time. I will just share our experience with FET. As we all know, we could not do FET till recently because the product was not available. I remember the talk given by Professor Roberto in 2007 in Liverpool Heart Center meeting when he presented, I think, more than 150 cases of FET. But ever since the device was not available, so we were not doing it. Now the indications of FET all of us know. I don't have to talk details on that. The treatment goal.
How much it is not since? Oh, this one. Yeah, this one is. Oh, I've been holding that. No, it has to be like. Oh, like this. Yes, yes. Oh, I've been holding like that. The sheet. It's the sheet. It comes from. All right. Run a little faster. Doesn't matter. It's 40. Okay. Okay. What we'll do is needle holder. Cardiotomy. Yeah, inflate. No, stop. Yeah. Clamp? Yeah, you can. No, yeah, beside the below that, you know.
Thank you, sir. Now I request Dr. Durgapur to enlighten us about the key points on thoracic aortic surgery.
Good morning, everybody. Thank you again for the invitation to present this my thoracic aortic surgery, my distribution. It's been estimated that radio root operation may eventually account for 10% of all ascending aorta surgical procedures. This is our experience. Due to the increasing incidence of aortic disease in the aged population and to the increasing number of cardiac aortic procedure with the use of biological aortic valve root prosthesis and valve sparing procedure. Aneurysmal or dissecting progression of the aortic disease in the mechanical or infective surgical complication represent the main indication for preoperative surgery of the aortic root. Finally, to resect all diseased aortic tissue increase the probability of subsequent operation, and considering the contemporary excellent outcomes after elective ascending aorta replacement, justify a more aggressive management of the aortic disease at the initial surgery. Preoperative surgery of aortic root continue to represent a great challenge for the cardiac surgeon. Main concerns include, on the one hand, the management of the chest re-entry, cardiopulmonary bypass institution, and myocardial and brain protection, and on the other hand, the specific
through the side branch of the prosthesis, and the rewarming of the patient was initiated. Lab subclavian artery anastomosis was performed with the third side branch of the Thoraflex prosthesis. The vascular prosthesis was then clamped in order to complete the proximal root reconstruction with a mechanical bender procedure. After the prosthesis to prosthesis anastomosis and the arch reconstruction was finally completed with the left common carotid artery and innominated artery reimplantation using the side branch of the hybrid graft. This is the anastomosis between the arch and the ascending aorta. I use for this anastomosis 500 Prolene, and this is the reimplantation of the left and innominate artery. The postoperative angio-CT scan showed a good final result. Since early 2000, we acquired a wide experience in radiosurgery both for proximal and distal aortic disease. The results significantly improved over the last 30 years. Our last work, it is the review of the entire series of 453 patients. Now our experience exceeds 1,000 cases, is around 1,500. The majority of patients were referred for chronic disease, such as degenerative aneurysm or residual dissection. Surgical complications account for only 1/4 of cases, and few patients had an acute aortic dissection. Interestingly, indication for radiosurgery affect here a long-term result. In 70% of the cases, a central arterial cannulation was performed, and the analysis of outcome focused on the comparison between proximal and distal aortic replacement. Distal aortic repair carried a higher postoperative morbidity in terms of ICU stay, renal failure, respiratory failure, and neurological events. Nevertheless, the 30-day mortality was similar in two groups. On the other hand, distal surgery demonstrated a lower long-term survival and a higher rate of reoperation at the follow-up. In conclusion, reoperative aortic surgery is increasingly performed, and appropriate surgical strategy, techniques, and methods for organ protection are crucial to obtain favorable postoperative outcome. In our experience, short and long-term results were excellent. The well-known progressive nature of aortic disease and the favorable result of elective primary aortic intervention would suggest aggressive resection of the diseased aortic tissue at initial surgery and close clinical and imaging survival. Thank you very much for the attention.
Many congratulations, sir, for this wonderful results. So just one request what you would like to say about young surgeons doing their primary aortic surgery, a complex aortic surgery, and how would they prevent a redo, number one, in terms of closure. Say, would you like to close with pericardium, or would you like to give a thymic cover so that the re-entry becomes easy? What is your strategy? Because generally it becomes so bulky there that there is hardly any space for any cover of any grafts or anything like that, sir.
For ascending aorta.
For ascending aorta. Sir.
For ascending aorta, I put the normal bendal procedure or David procedure with the Valsalva prosthesis. I use Valsalva prosthesis.
Sure.
And I have very accurate accurate technique to prevent the bleeding from coronary reimplantation first, and for the distal anastomosis. Generally, I use for distal anastomosis to put the Teflon felt inside and outside of the aorta, or the distal aorta, because there is the disease of the aorta, naturally.
Right.
And if the aorta, the diameter is small, only outside or sometimes inside the pericardial belt. If the prosthesis near the sternum, I put something to prevent.
Correct.
Many times the pericardial or the some stitch is, I don't remember now the name of that is in Italy, to prevent this attack.
Would you ever use an external pericardial to just give it a cover, or just?
This is the pericardial. If there is generally in the redo operation,
sir,
you don't have the non-pericardial or the.
No, sir. I'm talking about the index surgery.
The pericardial of the nerve.
Thank you, sir. Thank you. Any questions? No,
thank you.
Thank you, sir. Now I call upon Dr. M.V. Kamath, sir, the lead consultant in Department of CTVS, Apollo Hospital, New Mumbai, to share his experience on commando procedure.
Good afternoon, ladies and gentlemen. We are already running half an hour late, so it's a big procedure, but I'll try and skip the basics and just go to the videos. Feel free to stop me if any time you want to see a little more. At the outset, I would like to thank the organizers for the opportunity and the audience for staying patient till the lunch session. Yeah, commando operation is not just one operation, it's a spectrum, and we'll see what are the different modifications and where do they fit and how it is to be done. So let's go one by one. So it's an operation which is less preferred, more feared, maybe because of its complexity or maybe because of increased mortality. But is it true? Let's see. So I'll skip over this because we all know the anatomy, and it's a procedure which involves repair and reconstruction of intervalvular fibrosa, and that's what is marked by this line, and our surgery goes through this area. So it all began in early 80s when Dr. Cooley did the mitral valve replacement through the aorta, but then very quickly in a span of about 2 years, it is this man who devised this surgery, and they published their first series in 1997 after a year experience of about 43 cases over 12 years. If you see there, 30% of these cases, surgeries were done for infective endocarditis, and rest of the 2/3 were made constituted by the cases for extensive calcification, redo double valves, or narrow aortic and mitral routes. So this procedure even the best of the hands had a mortality of around 16%, and 6-year survival was only about 50%. 8 years later, they published the larger series where they had 76 cases, and if you see, the infective endocarditis cases has gone up by only 1, from 14 to 15, whereas the other indications, the number of surgeries have gone up almost double. So what it goes to show is even Dr. Tyrone David realized it's a procedure which has got better outcomes when it is done for an elective indication and has a very bad outcomes when it is done for an infective endocarditis. What does it mean to say? It says that the mortality associated with the procedure is not the surgical mortality, it is the mortality is related to the clinical situation or the severity or the multi-organ dysfunction that the infective endocarditis patients come with. So let me quickly, so this is Leipzig experience. So Tyrone David has published mortality of about 16%, whereas elsewhere it is far higher. It's more than 35%. So these are the common indications, and this is our experience. Even in our experience, we have only one mortality, and that too was for an infective endocarditis. Not a single mortality in the elective indications, especially for the redo double valves or commando Bentals. So I'll just give you 4 cases which are representative of these 4 indications. So the first and the second case are for the infective endocarditis, where it is a prosthetic valve endocarditis 1 or 2 months later. One was a 55-year-old patient and the second one was a 76-year. Both came in sepsis, AKI and a shock. So both had a destroyed aortic valve, a root abscess which was extending into the AML. So what is the procedure? The ideal procedure for that would be a hemi-commando, wherein you need, the minimum requirement for doing this procedure is you need a intact free edge of the AML and a cordis. Even if the entire AML and aortic root is destroyed, you can reconstruct it by a homograft with a mitral valve component with that. But unfortunately, we didn't have the homograft, so what we did was we used a modified technique wherein instead of the homograft, we used an autologous pericardium to reconstruct the AML and the part of the aortic annulus, and took that flap onto the ascending aorta and then fixed the aortic valve in that pericardial patch. So this is the third case. This is the elective indication, and this is where the outcomes are excellent and one should not fear doing this operation. So it's a 56-year-old lady, post double valve replacement with a bioprosthetic valve. Both the bioprosthetic valves are degenerated, very little intervalvular fibrosa on the CT scan, and both were small valves like 25 and 19. So she had a higher BSA, we had to give her a bigger size valve, and with absence of intervalvular fibrosa, the only option left with us was to do this thing. So how we do it? We do it, the redo surgery, all the similar steps. Only thing is we explant the aortic valve and check if there is any intervalvular fibrosa. If it is there, then we simply do a redo DVR. If there is no intervalvular fibrosa, then we go ahead for a commando operation. So the audio is not there with this. Yeah, so here we have opened the aorta and made a cut, explanted the aortic valve and extended the incision into the mitral annulus. Now we are explanting the aortic valve. Mitral valve. This is the mitral valve explantation. There is nothing great in this, and I'll just move ahead. So once we explant this valve, then we seed the prosthetic mitral valve on the 2/3 of the circumference of the valve is placed in that defect created by this, and the remaining, see, we have the 2/3 circumference of the sewing ring is fixed with the annulus that is there. The remaining anterior thing is covered with a pericardial patch, That will be seen in the next one. Yeah. So here we have already seated the mitral valve, and on the posterior, on the true annulus, the 2/3 of the circumference, the remaining 1/3 is covered with the folded pericardial patch. One goes on the LA roof, the other one ascends along the ascending aorta. And at the corners, it is very important to fix this pericardial patch with the intervalvular fibrosa and the annulus of the sewing ring of the mitral valve. So already I have covered all these things. Only thing here is when you seat the mitral valve, if you oversize the mitral valve, you need to see the height of the valve and how you are going to place the aortic valve. If you take a too bigger a valve, your aortic, on the mitral valve, the aortic valve is seating higher and your coronaries go below this thing. In that situation, you might have to do a commando Bental, which I will show you to the next case. So this is the interesting case which I would like people to participate with their opinions. It's a 23-year-old lady, 6 months pregnancy, symptomatic with a dyspnea on exertion, functional class 3. Echo revealed a bicuspid aortic valve with severe AS and a moderate AR. Aortic annulus was 14, mitral annulus was 23. She underwent a balloon aortic valve dilatation followed by LSCS, and then even post-pregnancy, post-delivery, she continued to have higher gradients. And a T was done that showed it is not a bicuspid, it's a unicuspid aortic valve, and the ascending aorta was also dilated. So we did a imaging which also showed us she also had a hypertrophic cardiomyopathy with a septal thickness of 23 and a SAM and a moderate to severe eccentric MR. So multiple problems: small annuli, unicuspid aortic valve, narrow aortic root, dilated ascending aorta, hypertrophic cardiomyopathy. What will you do? And a BSC of 1.5. So DVR, what about the PPM? Root enlargement, which technique, and what will you do for the mitral valve? Annulus is only 23. Septal myectomy through 14 mm annulus, very difficult. Ascending aorta aneurysm also needs to be addressed. Small LV cavity, LV volume was only 24. Multiple problems, and we needed one common solution. And the solution is commando Bental with extended septal myectomy. That's the first case ever done so far. So this is a video of the aortic valve. It's a unicuspid aortic valve, and you can see just the tip of the sucker is going in, and a very narrow aortic root. And this is a video of aortic valve excision. Then nothing, this thing, I'll just quickly skip this. Yeah. So here you can see the aorta is cut into the NCC and it's extended into the AML. Aortic anterior mitral leaflet is excised. The PML is preserved, and you can see the two sutures here, this one and this one. This is where you take two stage sutures and cut the aorta in between, so that you know that they should come together on the annulus. And there was a septal hypertrophy. And you can see that white patch on the turbulence and the papillary muscle hypertrophy. So we've harvested the coronary buttons, and now we are made the cut into the hypertrophic muscle, and we'll be resecting the muscle. So that muscle is resected in 2 stages. First cut is up to the mid cavity, and then you take it up to the base of the papillary muscles as it is shown there. And then we release the papillary muscles. Yeah, this is the resection of the hypertrophic muscle. I can't fast forward this, you'll have to bear with me. We resect this, and then we release the papillary muscles which are adherent to the septum, And then we do a little bit of papillary muscle thinning as well, because they were kissing papillary muscles, occluding the LVOT, and LV cavity also had to be increased. Okay, we have 3 minutes. I think hopefully we should be able to wind up before that. Yeah, now this is where you see I am trying to release the papillary muscle from the septal attachment, and after that I would be thinning the papillary muscles as well. I think I have made my point in this video, so let me move to the next one. Yeah, so here the mitral valve is seated after the resection. And the most important thing that is going to come is the sizing of the aortic valve and how do you place. So yeah, so now we have already seated the 2/3 circumference of the mitral valve, and the anterior or the superior circumference is left. The corner where we had cut the aortic annulus have come closer there. Now we take a folded pericardial patch and fix it with the sewing ring. The issue comes here is now you look at the LVOT, it is never a circular LVOT, it will be a D-shaped LVOT. And now we have put a bigger valve, now we have put a 25 valve in a 23 annulus, and the sewing ring is higher than your coronary osteus. So if you place an aortic valve, and you need a gap of around at least 5 to 10 millimeters above the mitral valve sewing ring to avoid tussle between the two valves. So if you put that aortic valve at that level, your coronaries go down. So then what you need to do is you need to create a cabrol and put that cabrol on top of the aortic valve. So how we do that? We create a French cuff which will be anastomosed, sutured to the sewing ring and to the native annulus. How that French cuff is created, we fold a graft and then suture the aortic valve and then unfold the sewing ring. So below the aortic valve you will have a length of graft which you can tailor it to the position. Like on the valve you cut it little more, and on the annulus it is little longer. So your aortic valve would be sitting around 0.5 centimeters above the mitral valve level, and your coronaries have to be brought above the aortic valve by a cabrol. See, this is what is the graft. So first you fold the graft, suture it to the edge and then unfold it. So yeah, we make a cut there, and that portion goes on to the mitral annulus, and the longer one goes to the true annulus of the aortic valve. Yeah, so it's all about seating the valve. I'll skip this. And you can see here the cabrol, the two coronaries are end-to-end anastomosis, and the side of that cabrol graft is anastomosed to the aorta. So that's all. So the post-op gradients are single digits. This is another procedure that is described similar to this. But there they open the RA also and go through the intraatrial septum as well. So the take-home message is it is a procedure which is less preferred, more feared, but there is no need to fear about. When used for a correct indication, it has got a good outcomes, and the poor outcomes were related to the sepsis and the AKI and the shock that the patients come with. Outcomes of commando and commando ventals are encouraging and reproducible when used for a correct indication. And doing these procedures for elective indications improve your outcomes for even when you do it for the infective endocarditis cases. And surgeons must be aware of all the anatomical structures around in that region, and also know the multiple modifications of this technique to fit the right procedure for the right disease. Thank you.
Wonderful presentation. Just a comment for the complex case HOCM. Probably if we had done a Roscono, could have got away with a simple Roscono, because mitral valve, maybe it was a SAM. So if you do a proper myomectomy, it's probably mitral regurgitation.
That is what, doing a myectomy in a hypertrophic septum, ROS is going to be even more difficult, and doing it through a 14 millimeter annulus was a...
You are going to enlarge. No? If you do a cono, you already taken care of the HOCM and the enlargement, anterior enlargement.
But the mitral valve was also, there was...
organically diseased.
Yeah, organically diseased. It was a thickened leaflet. So that also had to be addressed, and it was a small annulus. And doing anything after a ROS was a...
Yeah, if you had to go back...
Yeah, we thought about the ROS also, and this patient went around, I operated this in Delhi. This patient went around all the centers, took opinion, was roaming around for 6-7 months, and then finally we discussed with the family and offered all the things, and then we decided she's still doing well.
Great job.
Yeah,
thank you.
Thank you, sir. Now we'll have a group photo, sir. I call upon Dr. Roberto de Bartolomeo, sir. Dr. Bashi sir has already left, so Kamath sir, please join us on stage. And they have left, sir. So. Thank you, sir. So now we move on to the last session, that is perfusion management. So the chairperson for this session are Dr. Vikas Kesri, sir, Dr. Sujay Chatterjee, Dr. Lakshmi Kumar, Dr. Sanjay Sen Gupta. I request the chairperson to kindly chair the session. I request Mr. Kajal Pan to deliver a talk on perfusion strategies on aortic heart surgery.
Thank you. Thank you, sir, giving me that opportunity. I am honored to speaking with all today. Today I would like to speak on perfusion strategies for aortic root and arch surgery. Next. This is to understand the basic idea of aortic morphology. In aortic arch pathology, we have Stanford classification type A and type B. We are concerned with the type A and type B, where it is ascending aorta and arches involved. Open heart aortic surgery replacement is a complex and challenging procedure, especially in post-dissection aneurysm and the redo procedure after previous surgery of the ascending aorta of aortic root. Need a meticulous planning and team effort for better outcome. The selection of cannulation and perfusion strategy as well as perfusion management is very critical to ensure end organ protection and positive patient outcome. So some sort of preparation is needed before the patient will in operation room. We see record of similar patient
operated in earlier, check equipments, technique, and we also see if any problem is faced earlier. So some OT preparation also needed for aortic surgery from perfusion perspectives is needed before surgery. Ensure that all perfusion equipment, including the CPP machine, oxygenator, heat exchanger are good working order or not, and all size of cannula, connector, graft is kept ready for the surgery. And check for cardiac lesion, aortic valve stenotic or regurgitant, coronary artery disease or normal, aorta is aneurysmal aorta or dissection aorta. So planning is very crucial in aortic surgery. So plan for, this is our routine, medium sternotomy, cannulation side distal innominate or axillary, left common carotid artery, and many times femoral artery also, and for venous cannulation, SBC and IVC. Myocardial preservation, we started with retrograde and then antegrade cardioplasia and surface cooling and left ventricular venting. For brain and organ protection, hypothermia and selective antegrade cerebral perfusion. This is our CVP circuit. CVP is conducted the SANS 8000 or APS-1 with 5 roller pump, and 4 cardiotomies occur, and temperature is measured at the venous reservoir inlet and oxygenator outlet. And we divided our line in arterial line in 3 parts, one for ascending aorta or axillary or brachiocephalic, and another one is left common carotid, and third one is side arm of the graft. Circuit priming, this is our priming composition, and that circuit, the priming volume is around 1300 ml. So arterial cannulation is the most important strategy, and it is determined the surgical outcome in aortic surgery. The right cannulation strategy to choose on the based on very special factors, especially disease, extension of disease, and idea should be easy, quick, remove complication like malperfusion. The aim of cannulation strategy is perfusion to the true lumen, malperfusion prevention, and cerebral perfusion. So this is our cannulation strategy. We put 8 mm background graft in innominate, first choice is innominate, and then or right axillary artery, and RDB true lumen cannula or cuffed ET tube for left common carotid during antegrade cerebral perfusion. Innominate artery and axillary artery with graft, it is our practice. There is many advantage like avoid the malperfusion of cerebral artery during SSAP, enable right arm perfusion during cardiopulmonary bypass, repair of the arteriotomy avoided by side graft cannulation. In case CT shows any occlusion of right vertebral artery or dominant and left vertebral artery, then we put an extra cannula to the left subclavian artery also. And if ever needed to femoral cannulation, then we put a biomedicus or Livanova biflow cannula for better limb perfusion, and angle tip venous cannula for SBC and IVC. Myocardial preservation, always we started through retrograde cardioplasia, the flow of 150 to 200 ml per minute. The line pressure we keep 15 millimeter of mercury, and then give left and right ostial cardioplasia. And after first we give isothermic blood cardioplasia. Then after 8 to 10 minutes we give delito cardioplasia. This is our delito cardioplasia composition. And this is arterial line preparation for heart surgery. We divided the arterial line into 3 parts with different size of connector. So we can divide the flow into the different percentage. And this is the another circuit you can we using also, that for we use the separate pump for during SSCP to give to integrate cerebral perfusion. You can see from main pump we divided the line with 3/8 connector, one for innominate artery and another one is for side arm graft, and another pump we use for selectively perfuse the left common carotid artery at the flow of 3 to 5 ml per minute per kg. Cerebral and organ protection concept play an important role. So core temperature is 25 to 26 degrees centigrade, selective integrate cerebral perfusion, innominate or right axillary and left common carotid artery, maintain right radial pressure 45 to 55 millimeter of mercury, topical cooling, CO2 flushing in the cavity during distal anastomosis, and we give methylprednisolone 1 gram. This is our flow strategy. The perfusion strategy is to deliver 8 to 12 ml per kg per minute flow at the temperature of 25 degrees centigrade to the head, upper body by innominate or right axillary artery and left common carotid artery. If you use the separate pump, then we give 8 to 10 ml in innominate and 4 to 5 ml to the left common carotid artery. So many study has shown that higher intracranial pressure with increased cerebral blood flow may result in cerebral injury and poorer neurological outcome. So high flow during selective cerebral perfusion significantly increase cerebral blood flow and intracranial pressure, resulting in cerebral edema with no benefit for cerebral metabolism. That's why we should very careful about the flow. Intraoperative monitoring. Intraoperative monitoring involves invasive pressure monitoring of the right radial, left femoral arterial pressure, central venous pressure, and selective anterior cerebral line pressure is also important. And temperature probe is inserted to the measure bladder temperature and urine output. Cerebral oxygen saturation via NIRS. And after restoring the restoration of lower body perfusion, the following things should be monitored, like AVG, pressure, right radial pressure, femoral pressure, and say for urine output. If there is any acidosis, please you should correct it immediately. And during CVP, blood gas is measured at 30 minutes intervals, alpha-state management strategy, hematocrit 30%, above 30% during rewarming, maintenance pump flow 2.6 liter per minute during cooling period for better cooling, ACT kept 400 seconds, and continuous hemofiltration, temperature management. So, changes in perfusion practice in aortic surgery over the last decade have been significant, driven by advance in technology, research, and clinical experience. Here is some key developments here. We used to do T monitoring, right radial pressure, AVG, mixed venous saturation, normal practice in arterial cannula for SSCP, pediatric cannula for SSCP, total circulatory arrest, temperature cool down to 18 degree for DHCA. But now we are able to have a smooth landing. Now we are able to multiple pressure monitoring NIRS, goal directed perfusion, specific cannula for ACCP, avoiding total circulatory arrest and lower body hypothermia. So preoperative evaluation also help us for successful SSCP, better organ protection, prevention of cerebral injury. So this is my experience in aortic surgery in my institution, and I am very grateful to my institution from which I learned many things from here, and thank you very much, sir. Under the shadow of your love and guidance, I am here today. And finally, I would like to thank my team. Thank you.
Thank you. Next we have Mr. Somnath to deliver a talk on partial CPB perfusion strategy for open thoracoabdominal aneurysm repair.
Slide change by
Good afternoon all. After 2 days of entire aortic session, I have learned a lot, and I would like to say I have started my career before 12 years ago from the Mission Hospital. Now I am working at Narayana Health Ravindranath Tagore Hospital. Today my topic is partial CPB perfusion strategy for open thoracoabdominal aortic aneurysm repair with mild to moderate hypothermia. So thoracoabdominal aortic aneurysm repair, when surgeon choose open, the surgical repair itself a major challenge in vascular surgery. The surgery requires reattaching the multiple arteries to a synthetic graft, significant risks of stroke, renal failure, complications like paraplegia, even it is leading to disability or death. The main concern is repair itself risks ischemic and other damage to downstream organs like spinal cord, kidneys and visceral organs. This is the data series of papers. It is showing the operative mortality, post-operative spinal cord ischemia and renal failure, recurring dialysis, still in dissatisfaction with the results. So there are lots of different strategies is there. Different strategy from cardiac surgery, limited number, made it difficult to establish a standardized system. So to make a standardized system, the main perfusionist role is maintain the perfusion to the vital organs during aortic clamping, monitoring and maintaining hemodynamics during the procedure by stable blood flow and pressure, preventing the spinal cord ischemia, by doing the distal aortic perfusion, moderate hypothermia and measuring the CSF pressure during the procedure. And also it is important for thoracoabdominal cases, especially the blood to reduce the blood transfusion, the blood conservation technique and temperature management to reduce the metabolic demand and to maintain the perfusion for the entire organs. Nowadays, these are the strategies are presently available in the various institutes. The normothermic clamps with the rapid infusion, the femoral arterial, femoral venous CPB with DHCA, the open femoral venous and femoral arterial partial CPB, and closed system MICC minimal invasive circuit and left heart bypass. And this all are the depends on the intraoperative strategy by doing the degree of hypothermia and period of distal ischemia prevention. This partial bypass, this use of distal aortic perfusion for partial bypass management first reported in 1956 by Dr. Debicki, and after that in 1971 Dr. Connolly and colleagues, and shows that the benefits of the distal aortic perfusion and how to prevent the spinal cord ischemia during thoracoabdominal procedure. So now I am going to discuss the femoral modified partial bypass, how I am able to modify this circuit and what is our perfusion strategy by maintaining the hemodynamics for the upper extremity of the body and the distal perfusion. So for femoral partial bypass, this is nowadays by ESCTS, this is class 2A recommendation as left heart bypass. For partial CPB perfusion strategy, we initiate the cardiopulmonary bypass partially and patient reaches a new hemodynamic equilibrium, and supraaortic branches are mainly perfused from oxygenated blood originating from the left ventricle, and the lower body is perfused with the oxygenated blood from the CPB circuit. The intraoperative strategies are, we use full heparinization like as all CPB cases, permissive mild hypothermia, the reattachment segmental arteries, and CSF drainage and selective visceral and renal perfusion. This is the CPB circuit we are using, and this is the femoral venous line. We are draining the patient partially, and this is the new generation electronic venous occluder system. We can do the venous drainage by the intended percentage, and this is the electronic ultrasonic flow sensor. By attaching in this line, we can easily check how much blood is draining. For partial CPB, we don't need to do the full venous drainage. If we will do the full venous drainage, the heart will not be able to eject for the upper extremity perfusion, will not able to maintain the CSF pressure also. And we use 3 separate pumps, one for visceral pumps for the celiac and SMA perfusion, and this is the cold renal perfusion circuit. Another, it is blood taking from the oxygenator, and for renal perfusion we do use cold blood perfusion for the renal perfusion, and one for AV shunt or volume support line. If preload is, we drain the patient excessively, and we can maintain again the heart its a volume for the ejection and to maintain the upper extremity pressure by this line, and this will be connected to the anesthesia side, neck sheath or neck line catheter. For distal aortic perfusion, we generally give 1.5 to 2.5 liter of flow. It is around 40 to 50% of the flow. For upper body, we do maintain mean pressure of 80 to 90 millimeter of mercury, and for lower body, 60 to 70 millimeter of mercury. And after attachment of the graft, we give always pulsatile perfusion to the visceral organs, and we do maintain mild hypothermia 30 to 34 degrees centigrade, and we can easily check the preload by attaching the available devices. And CSF pressure we do maintain 8 to 12 millimeter of mercury, and for selective renal perfusion, 150 to 200 ml, and celiac tank and SMA perfusion 200 to 300 ml. The novelty of this technique is electronic venous occluder system can accurately control the venous drainage by clamping the venous line according to the intended percentage. And this is also important, use of smaller size of femoral venous cannula, 19 or 21 frames. It is enough to drain the 40 to 50% from the patient venous system. And pulsatile perfusion to the lower body and isolated viscera as and when anastomosis is established. And mild to moderate hypothermia, we do maintain 30 to 34 degrees centigrade. And for monitoring For upper extremity, we use NIRS, and this is the arterial pressure. This is the ejected blood pressure. For the radial pressure, it is getting monitored. And this is the pulsatile perfusion we are giving from the pump. It is distal aortic perfusion pressure. And this is the CSF pressure. We always make it 8 to 12 millimeter of mercury, less than 15. This is the pulsatile perfusion we are giving, and this is the percentage we can check, and the attachment are already attached, and this is the renal perfusion is going on, and this is the flow sensor attached in the venous line. We can check how much preload is getting deducted from the patient, and that much of volume we are giving perfuse to the patient. These all are the same. The visceral and renal perfusion, this is nowadays also class 1 recommendation. Nowadays we are not giving any femoral arterial cannula. We just directly start the distal anastomosis with the cochlear graft and start perfusion with the side arm of the cochlear graft, and we give start perfuse, partial CPV, and we do anastomose the visceral organs and renal arteries by continuing while doing the continuous perfusion to the visceral or renal organs. We continue attached it. We can check the heart is beating, and it is we are maintaining the upper extremity, and we are giving continuous perfusion through this, and it is getting perfused, and this is also pulsatile perfusion. For visceral and renal perfusion while giving, we can check hepatic venous Doppler, and this is also a marker that adequate flow is going towards the visceral organs, SMA or celiac or not. This is our CSF drainage protocol or spinal cord protection protocol, and for modified partial bypass, CSF pressure we do maintain 8 to 12 millimeter of mercury, and the drainage is limited to 10 ml per hour, and it is a maximum up to 240 ml per day. These are the cases we have done with the partial bypass. Even in descending thoracic aortic aneurysm, also we have used the partial bypass management. This femoral partial bypass, this is Stanford University routine practice for thoracoabdominal aortic aneurysm cases. This helps to the surgeon improve exposure and option for adjunctive equipment. There should be no cannulas in the operating field, like as a left heart bypass. And sometime while doing the thoracoabdominal aortic aneurysm or DTA aneurysm repair, because of the size of the huge size of the aneurysm, it is getting difficult to cannulate the left atrium for left heart bypass also. That time partial bypass may be a good option. So these are the comparison, left heart bypass and the partial bypass. We can immediately harvest and return the shed blood, and for left heart bypass, delay in return of shed blood to cell saver processing, and for partial bypass, preservation of coagulation components lost in plasma removal by cell saver, and loss of coagulation component in plasma removal by cell saver also is there if we do cell saver continuous. And for oxygenation of desaturated blood from down lung, allow reliable oxygenation of the patient throughout the procedure without relying on the dependent right lung. And it is kinetically enhanced drainage. The disadvantage is full heparinization in left heart bypass. We can reduce the heparin dose, but there is a heparin reversal option also, like as a routine CPP, and this is also a common regular practice like a CPP, and this is very easy to establish by the perfusionist, and this is cost effective, and left heart bypass is expensive. So Conclusion, left heart bypass traditionally avoids high dose heparin lacking an oxygenator. Our technique with heparin reversal enables safe femoral venous femorolateral partial bypass with an oxygenator. Current technique use a venous reservoir, roller pump and oxygenator, improving blood retrieval and coagulation. Tailored perfusion strategy including cardiopulmonary bypass with controlled venous drainage via EVO system minimizes the ischemic injury during the thoracoabdominal complex aortic surgeries. Thank you.
I request Mr. Gajalpan to join us on the stage for a group photo. Group photo. Thank you, sir, for chairing the session. And here we come to the end of the conference. But before that, I would request Dr. Shirup Chatterjee, sir, for the valedictory note.
Well, what else is there to say? What a wonderful couple of days we have had. It is actually humbling to hear so many great speakers, and I'm sure, I hope you have all enjoyed it as much as we have enjoyed being here with you. A little while earlier, one of our speakers, who apart from a bit of Talmudic philosophy had divided the surgeons and are over here into three age group categories. I, of course, and many others have belonged to the last category, the older group. But I feel that I'm actually in the lower category because I've learned so much. And I hope all the young, middle, and old also will share the same sentiments. And it was a fantastic, we really enjoyed it, and I hope you all have. It remains for me to have great pleasure and pride in thanking and commending our organizing team, led, of course, by my colleague and dear friend, Dr. Bose, whose organizational skills by now everybody is familiar with, but he has been aided and abetted by our surgical team, Dr. Srikanth, Dr. Rahul, Dr. Rajeshi, and our postdoctoral fellows, Dr. Chaitanya, Dr. Murli, Dr. Virup, and of course, Manpreet, who's done a fantastic job emceeing the whole thing, whole session. And we must say, we have been ably aided and abetted by our secretarial staff, carried by Mrs. Tartini and Manisha and others. And then Dr. Rahul Keria and his whole management team who have been so helpful. And then when Dr. Bartholomew was operating, our surgical staff, my sister Jennifer and Kajol, our perfusionist, and all our other team. And I really feel a sense of pride of having been part of this team who has been able to hold this, and I hope you have enjoyed that. Of course, the greatest thanks is coming to all of you who have taken so much trouble to come all this way from various parts of the country. And of course, Dr. Bartholomew is not here. He's come all the way from Bologna and he operated. How wonderful it was to have him. And we also have many of our doyens of the cardiac surgery, past presidents, are there too numerous to enumerate, who have been with us, and young and old who come over here and sat patiently with us. Thank you so, so very much. And of course, I must thank our hosts over here, the management of the Fortune Hotel, and the catering staff for providing the meals. And last but not least, all this cannot be run without our sponsors. All right? I hope you've managed to attend some of the stalls over there. Our sponsors are really too numerous to mention, but we really have to thank them, because without them, we will not be able to hold these huge meetings. And I'll just mention a handful, if you don't mind. Life Tech, Medtronic, Edwards, Mankind Pharma, Sun Pharma, Cipla, Life Sciences, Pfizer, etc., and many others. And a heartfelt thanks to them. And once again, thanks to all of you for coming here. Thank you very much indeed. Heartfelt.
So we'll move for a lunch now. It's on 4th floor. Thank you so much. Yes.